it should be added to the when to reassess, and when we identify the risk factor, what are the interventions that we do to prevent the patient from having more. Usually, you know that we have an assessment, and part of it is physical, including the history, physical examination, and all the labs that we have. We need to think, we need not to forget the vision, hearing, and this is very essential, especially in elderly, the nutritional status, medication, and I was adding the dental and checking the patient, and you know, sometimes, especially the elderly, and when they are homebound or bedbound, or even they don't complain, but we need to screen for this. Adding to this, the psychological assessment is crucial. Screening for depression. Depression is very common, especially when the patient is having other complication or other disease. We need to screen. Simply, we need to know about the sadness or depression. If it's yes, we go for further workup, and further we have non-item patient health questionnaire and others to detect to diagnose the depression if it's not. Watch and sign for an anxiety and bereavement, and this is very common, especially in older people. You know, we need to know that we are taking care at home. We are taking care of really certain specified category of people. They are isolated, and they are, in the same time, they are having a chronic condition which leaves them isolated at home. So thinking about the psychological assessment to prevent the patient deteriorated is crucial in home care. On the other hand, social assessment, as all of you know, we cannot conduct the care. The family is really the one who are conducting the care, especially the caregiver. Assessing them, the availability, the burden, and also the economic well-being of the family and the safety of the home environment is crucial for conducting a safe practice and a safe home care. But patient functional status, including the activity of daily living, instrumental activity of daily living, quality of life. Quality of life, assessing the quality of life, as all of you know, we in home care, we think that we can make the family and the patient quality of life is better. Are we assessing this? Are we taking care of this so we can help and improve? And we need to think about this, and this is one of the things that we need to understand, that acknowledge the role of culture and understanding the health and wellness, because there is different cultures, and we are talking about the patient, their priority, and they think what is good for them, and when they get sick, they think in a different way. This includes the different aspects from physical, cognition, psychological, and social function, and we need to see the patient, consider the patient preference in regard to the medical care and the goal of care, and to improve the quality of life. Okay, fall, preventing fall. And this is the first case which I was talking about today. Prevention of fall can improve lives. Why? Why we focus on fall? What do you think? Is it common? في أحد ما طاح? Anyone has best experience on fall? And I think rarely, but you know, rarely that any one of us has never fallen in his life. Especially when we talk about older people, 30 to 40% of elderly fall every year, 30% of home health care patients fall every year, 51% of falls resulted in an injury, and about 5 to 10% of fall resulted in a serious injury. 62% of these injuries lead the patient to go to the emergency room. You go to يعني بالذات كبار السن. Once they fall, تبدأ المأساة. That's why we need to focus about fall for prevention, assessing and periodically assessing the risk of fall for the patient and the potential risk, especially that when we are giving the medication. يعني هذه المريضة اللي في الأول قلناها الصباح early morning, she was having imbalance. Why she's having imbalance? Why we did not take care of this? Did we assess this? Did we reflect this in the care plan? So we need to have an action to decrease or eliminate any identified factor that we can do. طبعا there is a different something we cannot change. which is age, gender, and the ethnic background, and some other things we can change, especially that when we see that the patient is having a visual problem, hearing problem, and this is something at the home environment, how you can make the home environment better, and this is one of the things. Knowing the things that you can change and reflecting it to the care plan can save lives and quality of life. For once, we need to assess the inside home hazard. Home are designed to living, not to do a care for. So it could be dangerous even for the team, the patient himself, and we know we should assess the home environment before accepting any patient. طبعا it's the commonest place إنه عادة patient fall in هو الباثروم, but other areas. But there is a lot of things can be done, modified. Some of it is very simple, just to give advices to avoid slithering things and to prepare the areas which is dangerous, especially for elderly, to change. We do a home assessment for all, from the entrance to the room, the bathroom, everywhere, which the patient will be available in, to make sure that what is the risks and how to prevent it so the patient will not fall again. The aim of fall assessment to identify patient at home for of risk, reduce the harm from fall, and this should be reflected in the care plan. We organize to assess and manage and report the falls so we can measure and know how much it's serious. The second thing is preventing pressure injuries. Pressure injuries is a main concern at home care, especially the home-bound patient. And to stop this, and we need to think why this is important. 30% of home health care patients are at risk of developing the pressure injuries. 11.6% of the patients have already pressure injuries, and the cost of curing one pressure injury is more than 10,000 per day. Other than this, there is quality of life, which is an unmeasurable thing. It's not related to the cost, and this is something that can be prevented. Preventing by assessment and assessment and assessment, and this assessment, there is a different assessment tool that can be, we should train the staff to do, and then reflect this in the care plan, how to educate the patient and caregiver to avoid the pressure injuries. Simple things can be done and avoid this dangerous thing, which is pressure injury. We need to ensure that the home is safe, available bed, air mattress, supplies that needed to be, and that's why community participation may be important here to help stop the pressure injuries. Prevention of infections. طبعا كورونا علمتنا الكثير, prevention and prevention, how to transmit. We as a healthcare provider, especially at everywhere, but at home care, we could transmit the infection to ourselves, to our families, or in between patient homes. For infection and prevention control is essential. Having the institute should have a program for preventing the infection. Infection control program should be there, and it's one of the أعتقد هو شابتر الآن في سباهي كامل. جبنا سباهي جد دكتور سلطان. شابتر كامل عن prevention is there for preventing the infection is one crucial. A lot of things need to be done. Team need to be trained to do, when to do, how to prevent the infection, and the ways of avoiding this, including even the staff health and immunization schedule, other than the patient. Cancer. Can we prevent cancers? Yeah, it could be prevented when appropriate. One of the things that I will talk about the prevention is screening. But screening needs to be individualized according to the patient condition, and it's not a stamp that's done for everyone. Sometimes screening at a certain age level, or the expected life span is at a low, make the patient at a higher risk rather than preventing from the deterioration. This is one of the things, screening for breast cancer. Breast cancer is one of the priority. Screening for breast cancer could save lives, but according to the evidence, the life expectancy, the life year expectancy should be 10 years or more to start the screening, and this is essential. Should be done every 2 years. There is two schools for this. After 40 years of age we start, but then I think in Saudi Arabia we need to start early, but not in mammogram. Other performed clinical breast examination periodically should be done. It's unknown that the mammogram result will do a benefit for elder ladies more than 75 years of old. There is no evidence for breast self-examination that it could reduce mortality or morbidity, but we need to think about the screening for breast cancer, especially when the life expectancy of our patient is more than 10 years. طبعا I'm a lead for choosing wisely, فحتلاقوا choosing wisely اتكتبت كثير اليوم. Choosing wisely is an initiative that looks for using the resources that we have and reducing the harm for the patients and not to do unnecessarily things. According to the choosing wisely, it's not recommended to screen older women who have their life expectancy less than 10 years. Screening for colorectal cancer. We need to know that colorectal cancer in Saudi Arabia is the first and is the main cancer. How to screen, when to screen. Usually, according to the recommendation, it's age of 50 to 75. لكن الآن الجايدلاينز ممكن في السعودية حتتغير. Maybe they will start earlier, especially if there is a family history of colon cancer. طبعا what we do is the FIT. Usually احنا نسوي الstool based test اللي هو FIT test. And this is one thing. لكن screening for adult who are 76 to 85 should be individualized, especially that, as I said, screening is according to the life expectancy of the patient. It's not recommended to screen any person above the age of 85. Decision about the first line screening should be individualized for the patient, especially the elderly. Prostate cancer, there is no evidence for the screening for prostate cancer. Lung cancer for smokers. Smokers, especially the adult in between 55 to 75, and they have heavy smokers, we screen them, and it's recommended to have a lung cancer low dose CT to diagnose or to screen for lung cancer. And this is also, we are seeing it. It's not recommended to do these things at a difference, which is the routine urine analysis, pap smear, ECG, which is not necessarily spirometry, which is not necessarily, and all of these are not, there is no evidence for it. The thyroid cancer screening, thyroid diseases, and the skin cancer, all of this is not recommended to screen, so we do unnecessarily. DEXA scan, at least should be done after the age of 65. Maybe the guidelines now in Saudi Arabia is going to change at a lower time. طبعا blood glucose, cholesterol level, blood pressure, weight and height, this is a routine thing and should be done, and we should reflect on this. طبعا this all reflect on the healthy lifestyle, the physical activity, nutrition, smoking cessation. وأنا بوقف شوية على smoking cessation. It is a responsibility for the healthcare providers whenever they find an adult who is smoker to just ask, are you a smoker or not, and emphasize that you have a high risk and we advise you to reduce. And this has been shown by evidence. It could help a lot in improving and smoking cessation, helping them to stop smoking. طبعا for geriatric or elderly, we need to have all this done, especially the mistreatment or abuse of the patient, and this should be done routinely, especially when we are at home and visiting the patient. Immunization. Immunization is crucial, is one of the corners of prevention. Influenza vaccine. Did you all get the influenza vaccine? influenza vaccine is number 1. Tetanus طبعا عادة booster every 10 years, especially herpes zoster now after the age of 50, 2 doses, and it should be given. Pneumococcal vaccine once after the age of 65. Recommendation, especially we recommend all adults after more than 65 years of age to have the pneumococcal. Risk factor include in which we go more immune compromised condition. طبعا هذا الجدول حق الفاكسين, especially the influenza, it's very crucial and we need to think about it and give it to the patient at home. and هذه الحالة اللي تكلمت عنها في الأول. طبعا إذا تكلمنا على الأسبرين is a very يعني طبعا في كثير من الكلام على الأسبرين, and when we talk about aspirin there is a lot of negotiation and it's not supposed to be generalized for everyone. لكن evidence has shown إنه البيشنت اللي عندهم already history of coronary vascular disease, it's recommended to have aspirin for a long time, low doses اللي هي 75. And this it has been shown إنها ما تسوي risk of bleeding عالي. كالسيوم and vitamin D. كالسيوم and vitamin D أنا أعتقد في السعودية وأنت مغمض عينك أعطي vitamin D for everyone. We don't get exposed to sun enough. يعني هو دائما يقول لك effective sun exposure هو الفرق. الحين patient يسألوا where is the source of vitamin D? It's the sun. Are we going to the sun? No. So you need to take the prophylaxis. Vitamin D is there. Calcium intake, especially in the elderly, we go at a higher dose, 1200 daily. طبعا multi vitamins عليها a lot of debate. مشكلة المالتي فيتامينز اللي موجودة في السوق إنها كلها they have additional added things. لكن ما في مشكلة, يعني إذا a patient insisting to take multivitamin let him take, لكن ما هو it's not recommended to take it for everyone. طبعا هذه recommendation حق choosing wisely. Don't use CT scan in healthy individual. It's not recommended to screen for breast cancer, colon cancer or any cancers without considering life expectancy, لأنه هذا يعمل over diagnosis. Don't repeat colorectal screening for 10 years after high quality colonoscopy. Don't perform routine cancer for dialysis patient or who have less life expectancy. To conclude, home care can improve quality of life, but if we do a good assessment and we focus on preventing all the risks that we find in the assessment, especially fall, pressure injuries, immunization should be considered, and we individualize every other thing for prevention. Home health care, recommendation about appropriate screening, counseling, immunization are available, and we should consider it. We need to think about the life expectancy, the cognitive status, the goal of the patient, and the patient preference when we go. Remember, prevention is better than cure, and we can do it. Thank you. جمعية. أنا بس الدكتورة حتعطيني دقيقة. طبعا احنا عندنا الجمعية السعودية للرعاية الصحية المنزلية Home Society of Saudi Scientific Home Healthcare Society has been established now. It's available. Please, if anyone would like to join us, this is the way to register. طبعا this is my email if you want to contact الجمعية at any time. We are specified to home care. We are so happy to have anyone of the people who's working in home care are interested to join. We'll have a conference in المدينة المنورة إن شاء الله next year فبراير. Just remember the date 7 to 9 صح? February 2000 إن شاء الله. It will be announced in our website and Twitter account. إيه
Just give us his name.
إيه
ممكن تسجل. مرحبا بالكل الجميع. If you need to register in the Saudi Society, Scientific Society of Home Health Care, just give us your name and registration number of your registration number, and we'll do it for you إن شاء الله تعالى.
Thank you. شكرا دكتورة مرفت, يعطيكم العافية. Thank you.
شكرا دكتورة عايشة for this valuable lecture. It is an honor for me also to present Dr. Walid Al-Kiraidi. Dr. Walid Al-Kiraidi is Director of Home Medical Administration and Ministry of Health. He's associate professor and consultant in King Saud University, affiliated associate professor at University of British Columbia, and geriatric medicine consultant at Pfizer Health Canada. Also, he's a member in Saudi member in the National Committee of Older Adult in Saudi Health Council, working as a deputy of Board Saudi Geriatric Society, and also working as a member of Scientific Board of Saudi Neurology Society, working with with Saudi Commission for Health Specialists as a leader of the team commissioned to develop first Saudi Geriatric postgraduate fellowship program. Dr. Walid, he will tell us about the future of home health care. Welcome, Dr. Walid.
هلو، مرحبا دكتور وليد، نورتنا وكنا نتمنى انك تكون معنا، لكن الف لا بأس عليك. يا ميت اهلا وسهلا، تفضل.
الله يعطيكم الصحة والعافية. I just want to make sure that the sound is working well. If you can just confirm that you guys can hear me.
Yes.
Okay. يعطيكم ألف عافية. Thank you so much, Dr. Mervet, for this invitation, and I'm really grateful for all the efforts that you're doing to improve the care in home care, and developing this great partnership between the private-public participation, and I'm really honored to be with you today. So today, my lecture is going to talk a little bit about the Saudi initiatives for age-friendly health system, which will definitely come across home health care. So basically, I'll start with some of the epidemiology related stuff, and let me hear. So basically, when it comes to the basic statistics for older adults in Saudi Arabia, we know that 4.4% of the Saudi population are older than 65. This number is really projected to reach 11% by 2030. As we know from the National Health Survey, 74% of older adults have chronic diseases, 31% require assistance for mobility, and around 30% require assistance for personal care. Compared to other countries, as you see on the right-hand side, Saudi people do not comprise a huge or a big portion of the population who are dependent compared to other countries like United States, Canada, and Japan. So we still have good opportunity to improve and include older adults in the society as well as the economy. So moving forward, when we look at the distribution for older adults in Saudi, we know that 24.5% of older adults are populated in Mecca, around 20% in Riyadh region, and 11.7% in the eastern region. This definitely can help us design our health system and mobilize our resources to areas that are populated with older adults. Basically, when we look at numbers, when you go back to the latest statistics, we find that around 2 million people in Saudi are above 60 years old, and if you look at the strata of age compared to the population pyramid, we still have some room to actually work on improving the infrastructure and healthcare in Saudi Arabia, because compared to other countries, the proportion of older adults in Saudi is still low compared to other either Arab countries or even international countries. This is just a comparison, and this data comes from our world in data. You can see that it is projected that this strata of age from 60s to 70s is going to quadruple or triple by the year 2050 and 2075. And you can see here on the left-hand side the proportion of women compared to men. I just want to point out that compared to the international world in Saudi, Actually, our pyramid is a little bit different in shape. Here you can see that the proportion of females are a little bit less compared to males. And when we met with the WHO this week, they actually pointed out that this is an interesting phenomenon that requires further studying, and will definitely can help us design our care model to cater for these changes. Depending on the latest results from the National Survey of National Health Survey, we see that most of the chronic diseases are basically focused on older adults. So you can see that people who are older than 60 to 80, around 44% of them have raised blood pressure compared to the younger group. We also see that from functional abilities, people who are older than 60 to 80, around 27% of them require assistance for activities of daily living. We also see that mental health is also common and widespread in this age population or age group, and around 40% to 26% describe themselves as feeling depressed or low. So you can actually appreciate the importance of analyzing these data and taking into account these results when you try to design a health model or a model of care catering for older adults. Why is this important for home care? I just want to remind you that around 80% of the home care population are older adults. So understanding these trends and these percentage is very important to help you design your either model of care or your home care service. So when it comes to workforce and capacity, we understand that we do have scarcity of specialists and geriatric service. So we have around 12 basically geriatric clinics in MOH. They are distributed across 10 regions out of 13 regions. So far, we only have 12 geriatricians to help cater for older adults. And as I mentioned previously, the gap is huge. It's around 330 geriatricians, but this does not even take into account the other allied healthcare staff, such as nurses, physiotherapists, and other allied health services that are required to provide services for older adults. In shifting here to the current services we have here in the MOH, so far we have 60,000 clients, or basically our target was to reach 60,000 clients by the end of 2023. By the end of 2022, basically. At this moment, we have served around, in 2022, we served around 66,000 patients or clients. Around 10,000 either got discharged or passed away. Currently, we have actively enrolled around 49,000 patients, and we are really are proud of our teams in MOH and basically helping us reach our target. We are serving basically from 287 hospitals in MOH. We have around 245 hospitals basically have active home care service. In terms of the teams, and this year we just added around 100 teams, so we currently have 612 home care team distributed across the kingdom. Up to November, we completed around 81,000 visits, and as I mentioned, we served around 66,384 clients. Just last week, we added 68 cars to the fleet of home care, reaching 538. And we started the distribution of the cars, starting with the C3, which is called the third cluster here in Riyadh, then the eastern region, and then by the end of the year, inshallah, every region will actually receive their quota of new allocated cars. We are also proud to have 2,708 allocated manpower. They are split between admin staff, drivers, dietitians, social workers, physiotherapists, RT, physicians, and nurses. As you may imagine, nurses comprise the biggest portion of the teams here in MOH, and we're working actually with the Saudi Commission for Health Specialists and the MOH to increase the number of diplomas either for physicians or nurses, and this will be a strategic goal for us in 2023, inshallah. So moving forward, I'm just gonna talk about the strength of the community of Saudi Arabia towards providing care to older adults. So as you know that some of you might know that the good thing is that the Saudi population is still a relatively young population. We also have a cohesive family unit, and alhamdulillah, we have availability and accessibility to basic medical resources across the kingdom. Recently, there was also an introduction by the custodian of the Holy Mosque, King Salman, and his approval of the Older Adults' Rights Law in 2022, which basically saves and protects the rights of older adults, either from social or health rights. Also, we do have a great, robust social services directed to older, vulnerable people. And last but not least, we have a national strategy caring for older adults that can be incorporated also and addresses the aspects of health, including home health care. I don't want to forget about the younger population, but since there are very well customized and historical laws protecting younger population, currently we do understand that there is a gap. However, there's also a great opportunities for us to serve older adults. There is a great appetite and support from our leadership to improve the healthcare services for all across the healthcare system, including home care. There is also a recent promise made by us here in the specialized administration for geriatric services and home care to accredit 4 health institutions as an age-friendly hospitals or institutions. The opportunity that's available as well is the availability of allied health care, young healthcare worker who can be trained to provide appropriate care for older adults. Also, there was a recent establishment of an executive committee that cross-cut between the public health as well as the therapeutic deputyship. And last but not least, we do have a scientific committee at this Saudi Commission for Health Services to advocate for capacity building for geriatric services and training. Moving forward, we want to let you know that we're working currently with the WHO to incorporate their major goals when it comes to the Healthy Decade Initiative. The Healthy Aging Initiative for Decade, and this would be one of our strategic goals for 2023. This is important for home care because we're trying to adopt the goals and perspectives as well as the action plan set by the UN and the WHO, and basically report the successes of the Saudi services across the kingdom. I wanted to introduce you to the main pillars of the healthy aging. So the WHO and the UN set 4 pillars. The first one is to change how we feel, think, and act towards aging and healthy aging. We also they also added ensuring that communities foster the abilities for older adults and delivering person-centered integrated care and primary healthcare service responsive to older adults across the health continuum. last but not least is to provide access to long-term care, home care for all the adults who needs it. What we did so far is basically, this is just an example of what we're trying to do to achieve these goals. First of all, I was assigned as, and I had the honor to be assigned as a focal point for the MOH for the Healthy Aging Initiative, as well as the dementia pathway. We also created this year the Administration for Geriatric Services, and as I mentioned, established the cross-sectoral committee, including care of older people in primary care and other, and this committee includes supporting departments such as human resources, nursing, and so forth. Last week, we conducted the first integrated care for older people in collaboration with the WHO to train non-geriatrician and basically build the capacity of specialists, or basically we're trying to train geriatric for non-geriatrician kind of program. And we were successful of attracting around 100% and more in terms of the attendance. We involved people from multiple sectors, including the human resources, King Khalid University or King Saud University, also invited some people from the private sector and so forth. And we're hoping that this workshop will continue to be conducted across the year. The aim of this workshop is to develop the capacity for non-geriatrician to have the basic training and abilities to deal with older adults in any setting, especially in primary healthcare setting. Moving forward, we advocated to, as I mentioned, implementation accreditation of 4 age-friendly institutions, as well as improving basically the pathways for home care to have to include home hemodialysis, home ventilation, postpartum and postnatal care, and lastly, palliative and hospice care. So far, we've also made multiple collaboration with NGOs to build the capacity for workforce and professional development for our staff. This is just a picture of our collaboration with WHO last week, and this workshop took around 3 to 5 days. 3 days. Started with the standards of age-friendly institution, then the capacity building on the ICOP program. And just to share with you the great news that I think most of you have learned about is the basically the expansion for services for older adults. This was represented in the national budget. And this is a promise made by our administration to accredit 4 age-friendly institutions, also to expand in the scope of service of home care, including home hemodialysis, home ventilation, and hospice care. Just to give you some background about hemodialysis, as you know that home hemodialysis was developed actually a very long time ago in the US in 1960s and in the UK. By the mids or the early of 1970, 60% of patients, around 60% of patients in the UK were on home hemodialysis, and 32% of patients in the US were receiving home hemodialysis. Home hemodialysis can be either assisted or unassisted. So when I say assisted, I mean assisted by a nurse or unassisted by a nurse or staff. There are multiple benefits for the home hemodialysis, including lower risk of death, improved blood pressure control, higher quality of life, and lower costs and better outcomes. The good thing about home hemodialysis is that it can also be utilized for people with palliative care. And however, there has to be some minimum requirement for an institution to be accredited for such service. Our role here in the MOH is not just to promote this type of service, but we also would like to put the minimum required standards, put the minimum policies for like a private institution to launch this service. I understand at this point it's just It's an uncharted territory, but moving forward, we will definitely work with our colleagues in the accreditation and licensing department here in the MOH to revise these criteria. One of the examples of the minimum required standard for home hemodialysis would include assessment of suitability, either of the client from cognitive perspective, mental perspective, and mobility perspective, assess the suitability of their house and the suitability and safety of the environment. Also, some of the recommendation we would make on licensing would be the availability of support network and support services for home hemodialysis, the safety of the house, the safety of the environment, and the safety of the equipment. Also, we will address staff expertise and qualifications. Last but not least, any program should also have a patient and caretaker training to ensure their ability to know how to deal with failures of the system and address them in a timely fashion. This is just a table to show you how common this type of service is across the world. You can see that around 18.2% in New Zealand of their clients are using. Sorry, how many minutes left?
5 minutes.
Yeah. Okay, perfect. 18.2% have home hemodialysis. So we should put a national target for us to basically improve investment in this area and improve the policies and the guidelines to ensure the safety of the service. Moving forward, the palliative care, most of you know that the specialized medical care for people living with serious medical illness, addressing either people with dementia, cancer, and heart failure. Palliative care improve symptom burden, increase patient and caregiver satisfaction, and help reduce the cost and decrease utilization of healthcare resources. There are different types and different models of home palliative care that can include either primary palliative care. So the primary care provider is the person who goes and visits the patient at home, or it can be heavily weighted on nursing, so home-based palliative care, and hospice-based and hospice-affiliated model, and a combination of the following, including multidisciplinary or interdisciplinary type of service. The last but not least is the postpartum and postnatal home care. So we really want to support the institutions and people who are interested in this type of service. We really think that this should be one of the main scopes of service in home care. We know that women go through physical, mental, and emotional changes. Postpartum home care refers to the measures taken to prevent complications and promote the health of mothers during the period of postpartum and improve the quality of their relation with their newborn. There are several benefits for postpartum home care, including coping with the new changes, prevention of mental and psychological complication, and improving quality of life. Just to summarize, our role here is to improve the well-being of older adults and people in home care through multiple initiatives. We want to improve the home care representation of primary health care to become one of the cornerstones of services. We also want to develop our community care and home health care to become more well-developed and specialized and attain to the and basically reach a target of around 1% of the total population, so reaching from 66,000 or 70,000 people in Saudi Arabia being served by home care to around 120, 130,000 by the end maybe of 2026, and also include multiple specialized services as we mentioned. Here is just some ways of doing that we are going to advocate for this at multiple levels, including the macro, meso, and micro level. Our level here would be to ensure the advocating for budgets, successful implementation of our strategic goals, monitoring and supporting monitoring body to ensure implementation, and developing best practice guidelines and help basically support professional training for our staff. And I would like to thank you so much for this invitation, and I hope that I gave you some ideas about our future plans. And I would like to thank you all for all what you're doing to improve the quality and the safety, as well as helping us improve the scope of service for home care across the kingdom. And hopefully with the next 3 to 5 years, we can compete with the international societies when it comes to the quality, the scope, and the capacity of our departments across the kingdom. Thank you so much.
Welcome, Doctor. Thank you so much. Our next speaker, Dr. Abdelaziz Sulaiman Al-Hamoud, is the Chief Medical Officer at Sahha Virtual Hospital, a state-of-the-art entity created by Saudi Ministry of Health. It is the one of the largest in the region and the first of its kind in the Middle East. Dr. Al-Hamoud holds the American Board of Family and Informative and Emergency Medicine. He will present about virtual care at hospital. Welcome, Doctor.
Assalamu alaikum. It's so good to be here. Thanks, Dr. Murfit, for the invitation. Speaking after Waleed and Aisha is a pleasure. We always reach out to each other and communicate when it comes to providing virtual care at home. We see that virtual care at home is the future. It's going to be it's going to be the routine. Going to the hospital will be something unusual. You might spend a lot of times doing a lot of preventive care, primary care, taking lab tests, doing imaging without going to the hospital. My goal in the next 15 minutes is to make everyone here coming back to their work space, thinking about how to make their patient experience better, how to really look at home care with a futuristic angle. Can you guys read this? The most important piece is the date, 1927. I'll read it for you. Dr. Gale in 1927 said, if we have telegraphy, why can't we have telemedicine? It's very interesting if you read it. They say, can't we, so that we could walk up to the radio machine, drop your dollar in the slot, take down the particular receiver for the telegraph, right? And then apply it to the part of your anatomy where the pain is. Doctors, please snicker. Okay. I would like to hear from others on these matters, and really he was just thinking about it, right? But then information did not move between places at that time. So if you look at the next slide, this is in 1874. 1874. Someone was injured at a station near Barrow Creek in Australia. And if you look at this, is from a newspaper. So we were informed by Mr. Todd that on Sunday night, Dr. Goss went to the telegraph office and was managing a wounded patient. Okay. I mean, the reason I have the whole piece here, because if you look at the other part, it says, later in the day, however, a change for the worse took place in Mr. Stapleton's condition, and he died the same day. But at least they were able to render some care. They were able to manage him. They were able to support the decision. This was a remote area. There's no doctors. There's no healthcare workers there. So when we talk about virtual care or telemedicine, it's everything. It's anything. This is my favorite this is what informs my decision when it comes to virtual care and the group. It covers a lot of things. It's basically any care that's done remotely to the patient, to their team, to between different groups. But virtual care is something that happens using technology remotely with the goal to really ease the burden and provide patient care. These are the examples that we have today. A lot of us had virtual appointments through, we're happy in Saudi that we have Maw'idi and Sahha and Sahhati or Maw'id. There's a lot of virtual appointments that's been going on. Virtual consultation between different providers. And I will try to link these to the home care experience in the next few slides. Virtual committees, virtual supervision for procedures, radiology, pathology, and other reportings, remote patient monitoring, and screening and triage virtually. Why do you need to do that? It's for the quadruple aim. I'm sure everybody has seen slides similar to this so many times. But really what matters is improve better outcome and improve patient experience with the clinical expertise and reduce cost. This should be in the core of any project that you do. How can you do that? This is the, I mean, I like to use the chain of success because we're used to seeing similar slides for the ACLS or trauma and things like that, where you have to build a fair chain of success. If you're informed by strategy, and in Saudi, with the vision, there's a lot of strategies around digital transformation. So you don't need to look no more. Strategy is there, the vision is there, the goals are there. Regulation is supportive. As Dr. Walid mentioned, a lot of committees now are looking at the regulations and trying to move it to allow us to achieve our goals. People, technology, and processes are the core of all these activities. The virtual hospital is where we do all these virtual cares solutions almost every day. So we had to come up with a very robust process. And luckily, we looked at Roger's innovation decision steps, and it met our needs almost perfectly. Whenever we come up with a case, a potential use case for virtual care, we try to design it. And Dr. Walid, as an example, came up with a couple. Dr. Aisha was part of quite a few. We build a use case, and then there is a national committee that sit down, and we try to persuade these committees to approve the merit of the use case. Once the thumb up sign is there, then we start working with the implementation sides. We look at the regulation, we look at the technology, we look at the people's skill, what kind of training, what kind of resources, what kind of things that we have to build before we go live. Once we go live, we try to go at a limited scope, try to test it with a mentality of a sandbox, and then we diffuse it across Saudi as it fit. This slide is where I always, when someone comes with an idea, with very, very impressive idea, something new, as an example, keratoconus in ophthalmology, something too fancy, I always say, just go back to this and imagine that there's, when you talk about home care or home-based care or virtual care, you want a person journey, a person who's not sick, to look at this at home, to think that, oh, if I need, for example, triage, I'm going to use a specific tool. If I need some sort of a lab test, I don't need to get out of my office or travel somewhere. I can do it from home. You need people to think about this. You need them to have a journey that can be done virtually. Always think of the physical journey. Back in the days, we have one-stop shop. Go to مدينة طبية أو go to مستشفى الشميسي مثلا, أو you'll get everything you need there. And then there is an emotional journey, because with home care, with virtual care, the responsibilities on the users or the patient is more. You have to do a lot of things actively. It's not a passive journey. I'll speak about two projects here in Saudi. started by a group in the virtual hospital with support from other partners, and we have the team from Medina Munawwara. The two ones that we'll talk about today is the remote patient monitoring for advanced heart failure and the acute care hospital at home. This is a condensed slide. I just want you guys to see how did we go about implementing similar project, and then you could apply it to any use case that you think will support your people or your team or your patient population. So for the remote patient monitoring for heart failure, we've seen a lot of advanced heart failure patients who keep being back and forth between hospitals and home, between emergency rooms, ICUs. And in every event, I look at it as a near miss, because they're overloaded, they're sick, their heart is pumping really hard, the risk of deterioration is there. The management team has to be expert. A lot of decisions making is there. Do you intubate? Do you give fluid? Do you give Lasix? Do you put in the ICU? Do you discharge? A lot of decisions. So we decided to, if you're going to do something at home, you have to have a very robust inclusion criteria. Yeah, your form has to be safe. You don't want to contribute to disasters or sadness. So we don't fly solo. The team of cardiologists led by Dr. Adil Tash here spent a lot of time, did a lot of benchmarking, came up with a clinical readiness assessment, and specific numbers. I didn't put the numbers here. I don't think it's relevant, and I want you guys to go and look it up. But yeah, a diagnosis of heart failure, a specific class of heart failure, a specific number for ejection fraction, a specific symptom. Let's say list of symptoms. When did the patient become symptomatic? How frequently does he go to the hospital? Because again, you don't want to use it as one blanket that covers everybody. Some people doesn't really need to be there. So a specific number of admissions or number of visits and whatnot, and then a specific level for because you want to be informed. You want to have some sort of standard way of working. So there's also a specific number of pro-PMB. But then that's from the disease journey. How about the patient and others? So we have success factors. You need to know, is this patient tech savvy? Is this person likes to try things? Some people don't want to change. They go to the same coffee shop every day. Others want to explore. So you want to see it from a cultural perspective, what kind of patient you're dealing with. And then from their home or their environment, do they have internet or not? For example, if they don't, can we access them if an emergency happens? Are they in the middle of nowhere? We need to airlift them if something happened. That's a big no. And then their caregivers. Do they have caregiver? Are they supported? And then an organizational culture, because any home-based care, you need to trust your partners. Your emergency EMS department, your inpatient, your colleagues who will take care of the patient when he comes. That's at different times. Enabling tools. We noticed that locations where medication can fly easily, can be distributed, they have a good logistic support, really made this possible. Technology, a lot of the heart failure technologies are not very sophisticated. It's basically for for weight, for respiratory, for vital signs, for the whole kit is not super sophisticated, but you want to make sure it's there. It can be managed remotely. It is integrated with your team monitoring group. And then it's very important when you come up with a virtual home program to ensure that you have specific goals to monitor. These are the list of the acute remote heart failure, RPM for heart failure goals. And again, it's here for you to kind of come up with a framework that helps you move forward. The teams are different. You can't just copy the inpatient team or the home care team and say, yeah, this is a group who will do remote patient monitoring or advanced virtual care at home. The care plan, these are just a list of activities that our care plan group has to do every day to ensure the safety of these patients. So for the RPM for heart failure, we've used it with two different teams, one in Al-Hassa, and the other one I can't remember. Qasim, yes. And you would see the difference, not based on the program itself, but based on the culture, based on the team, based on the, and I'm not saying one is better than the other, it's just a way to really look at it and then take into consideration that there is no way to come up with a national program that fits all groups the same. Okay, and we usually say, those are very active. Well, I like working with this group and whatnot, but usually because of the needs. If you don't look at my needs, I won't be excited to be part of it. Now, the team from Medina Munawwara will be excited for this slide because they were part of it and they continue to be part of it. So we sometimes during COVID we noticed that basically majority of our hospitals work at a very high capacity, 100%, 99% all the time. So I like to say this, we're 99% full, 99% of the time. Your team is stretched thin, you get confused sometimes between how to prioritize, and medicine is becoming complex. As an example, each ICU patient generates more than 1,400 data points that has to be reviewed daily. So without help, we can't do that. So when we decided to do the acute care hospital at home, I'm sure Dr. Aisha remember and the team from Medina, Dr. Waleed too, we did a lot of discussions, a lot of meetings, maybe 9-8 months just of meeting and reviewing the evidence and trying to see, is it safe? Can we do that? And we came up with just 5 use cases. And we were so proud that we made up our mind for a specific goal. And we were confident that these 5 use cases are safe. And then we looked to partner with hospitals. We started with R1 and R2 in Riyadh, and then Medina Munawwara came just a few weeks ago maybe. But they were part of a lot of discussions. We were informed by a lot of their work and how they look at acute care hospital at home, at their admission and whatnot. But then there's a lot of points that I wanted to really be in the back of your mind if you end up doing something similar. Look at the physicians, the physician group that you will hire, because this is more of an acute care. It's more of an inpatient, similar to an inpatient status. So think about your group. Are you going to use internal medicine physician? Are you going to use critical care physicians? Are you going to use GPs with some support? We decided to go with internal medicine consultants. The nursing, a lot of groups, when they talk about acute care hospital at home, their goal is to hire the most trained nurses who could make the call, because they will be making a lot of out-of-hospital decisions. This is unusual, especially for acute care. But as Waleed mentioned, hemodialysis is not an easy procedure, and it's been done at home. The chemotherapy team now is entertaining this idea. The enzyme therapy team is now doing it in some places. So I think in the future, home care nursing will be the most advanced, the most well-trained nursing. The way we do it, we do a lot of virtual nursing rounds. So over a weekend, for example, a home care patient enrolled in an acute care hospital at home might be seen 15 times between three virtual visits by the nurse in the hub, 1 to 2 home visits by the home care team, 2 rounds by the consultant, and constant ability to reach out to the patient, to the team. We've done it using 937, where if someone is enrolled in this program, when they call 937, immediately it goes to the person in call. So, yeah, we had to redesign the home. We want people to be out and about. They don't need to be in a bed, but similarly, you want to be able to monitor them. So we created the vital sign stations at home for them. And then this is a very tech-heavy project. So I usually share with the team the ratio of IT to MD at the virtual hospital. It is very interesting. A lot of work has been done using the different devices. And I just wanted to highlight that we do consultant-led rounds because these patients are usually in an acute care setting. The 3 questions that I want you guys to think of when you plan to do something similar: how to staff, what to monitor, and who to engage. I feel like when you have answers to these 3 questions, you're most likely going to succeed. Me, Dr. Aisha, Dr. Walid always have these small chats. What's next for virtual care at home? Digital therapeutics, I think this is going to come very soon and become the core of every prescription. When you get your prescription, I think you're going to get some sort of a digital therapeutics tool that help you assess the outcome. An example was done by a group at MIT. They tried to track how fast you can walk for patients with Parkinson, and they looked at how fast you walk after the medication and when it wears off. It's a very interesting way of looking at the impact of the medication from a patient-centric outcome. They're not looking at your liver enzyme, is it being hit or not or whatnot. No. You see how fast you can go to the bathroom, for example, after you take a specific medication or not. I think this is going to happen very soon.
Doctor, 5 minutes left.
Yeah. And then once you start putting a lot of home-based care, virtual home-based care or whatnot, you need to integrate with 911, with the Hilal Ahmar, with pre-hospital care. Because you don't want them to, when they go to the home, you don't want them to shut down the whole home care program and say, yeah, ship and go. Maybe there is something else that we could do. And Walid and I were talking about a national hotline for geriatrics and whatnot. I think that will be really helpful, especially if it's linked with the pre-hospital care. Rapid response team at home, and then the 3 use cases that I'm entertaining in these days are post-op care, oncology care, and palliative care. Thank you so much. I hope you enjoyed the presentation. Thanks.
Thank you, Dr. Abdulaziz. Now we have a break till 10:45. So, yes. Do you have a question for the previous? Actually,
I have a question.
Right.
Thank you so much, Doctor, for your presentation. It was valuable. Kindly, I need just to more elaboration about the RRT at home. How we can apply it, please?
So this is all the next future. I'm not very sure we could, but
even the imagination,
yeah, the imagination is instead of as an example, a big group in Saudi has their own RRT team who could go directly for a call. So instead of the patient calling 911, they would call their trusted hospital their trusted team. And the team will go there with a consultant, critical care physician, emergency care physician, with everything that they need. Okay? Majority of these cases ended up not transferred, but giving a lot of medication. And then, I mean, it's all over the publications if you look at it. For me, I have mixed feeling about it. That's why I look at it in the future, because you want an instant access to home. So I remember, for example, in other countries, when they pass the 5 minutes, it's a disaster. When EMS is not getting to your house within 5 minutes, oh my God, someone will be fired. So if you do an RRT, you can't staff RRT within 5 minutes of every home.
I hope it will be applicable later on. Thank you so much, Doctor. Do you have any questions, guys?
Doctor, thank you very much. The way I understand virtual hospital is that I mean, that's just my subtyping, is 3-level. Healthcare worker between each other, like in the rural area, and because I understand that you have already started, and I think King Faisal started it since mid-90, where they have some hubs that they usually communicate with, hospital in the periphery. And then the other one is between home and institute and the hospital. And the third one is between the community, like, lectures, presentation. My question to you, Doctor, in the future, I know that there has been really a trend, and I think the people who started it are mainly in the United States because of the cost of healthcare, including moving, hospital at home. So do you think that this will really substitute a hospital? I understand that technology is important. Do you think because really the trend that we see now is that all about technology. I don't know how many really junior consultants who can really examine for jugular nerve, raised jugular venous pressure. Okay, yeah, okay. So I think, would it really dissolve the clinical things that we have been learning in the college, and then goes with the technology? And is this a good way of doing it, even if it's saving money? Thank you.
شكرا يا دكتور. بصراحة أصبت كبد الحقيقة. نقطتين. الأولى, I'm gonna speak in Arabic when I'm very emotional. So, yeah, you can't do it using yesterday's tool for future goals. As an example, a lot of groups were telling us, let's deploy stethoscopes at home so a patient could do this and someone will listen to the murmur. Right. That's okay, that's nice, but that will not go anywhere by doing this. What could we do? And this is, for example, the example I said about the Parkinson disease. The team was just put a small place in there, a small machine in the house, and we will monitor everything. Your fall detection, your ability, and they were able to diagnose Parkinson 5 years before the symptoms starts by the respiration changes. So that's it. If you start diagnosing, for example, Parkinson 10 years before it actually shows any symptoms, this patient will not be admitted, will not, because we will start, at least we'll start early on, we'll manage, we'll design, even you might design their lifestyle in a way that fits. So it's about really transforming healthcare. It's not about doing what we do today virtually. That will never fly. If you look at the preventive care for colon cancer, for example, if you start doing fit for everybody, then we will stop having stage 4 colon cancer filling out the schedule of the physician. If you speak with any oncologist, they don't like to be engaged in preventive care because they have to manage very complex cases from 9 to 5 every day. They're working at the edge of healthcare. We'll bring it back. No hospital will be at full capacities. Hospitals will be there, but we won't have an emergency room with 20 hours waiting time. Because those people, we told them before they even felt the disease. That's why if you go to the first slide, it's the person journey. If you wait until they're patient, you're not going to go anywhere. It's a person journey. It's something that started. I was with a group last week, a global group. They talk about the life to death virtual cycle. It's not about how can we examine it. Even, for example, I had an ophthalmologist, and sorry, I'm taking up your coffee time, but I already had my coffee, I'm sorry. Yeah. An ophthalmologist was like, how would I make an ophthalmology assessment virtually? I'm like, I could tell you using some of the video tools today that pupil reaction, how big is the pupil is there. I could give you a full pediatric ophthalmology assessment using home health devices, stuff, ملعقة, مدري. There's a lot of applications on that. But if you're used to go and do percussion, you're not gonna, we can't do it. That's gonna go away. We'll have something else. I think that's my answer. And I think maybe not for me, maybe my grandkids, maybe grandkids. Maybe it will continue to be fantasy, we don't know. But there's ways to do it.
Thank you so much.
شكرا.
الله يعطيك العافية دكتور. الله يعطيك العافية دكتور. أنا سلطان الحوطي. صراحة مهتم جدا في الجودة. يعني امتدادا for the last sentence that you said that maybe your grandchildren يعني will have this luxury of utilizing virtual care at home. You started with a very nice اللي هو description that from 1927 that they imagine telemedicine. Hopefully inshallah coming a few years and we will see inshallah the improvement. What's prettier than the weather outside يعني أمانة your lecture here inside. Thank you very much for this informative lecture. And congratulations for the gold medal King Abdulaziz trophy for quality and also for virtual care award that you received I believe last month. You said something very interesting that يعني I figured it out from your speech that if there is no internet connection, this is equal that you are in the middle of nowhere. Even that if you are living in Riyadh, Jeddah, whatever, no internet connection, meaning that you are living alone in the desert. So my query here, virtual care, for this big segment, for this segment of people that have difficult of internet connection, how are you going to deal with this? This is one. Second part, I'm interested in quality, as I told you earlier, and in conditioning privileging. So how can we deal with this, challenges in privileging per se in home care? Thank you.
Abshir, shukran. Yeah, first of all, and this is also to your point, the virtual care is not going to replace anybody or something. It's good for some people. So I always highlight this. يمكن Dr. Tawfiq Rabi' Allah يعطيه العافية when he moved to Al-Hajj, he came by and looked at the Mecca and the Taif and Jedda's statistics. We're very clear. If infrastructure is what supports us, if you go and visit the virtual hospital, you will see a group from MCIT, من وزارة الاتصالات وتقنية المعلومات, dedicated for us. We're part of the design. We're part of the 5G future expansion, 6G or whatever. Sit down with us, say, hey, if you want to do virtual, if you want to use DaVinci in a different way, if you want to use remote, because I mean, I have a device in the virtual hospital today. It's not even FDA approved yet. It's for remote cath. Yeah. And the reason why it's there in the virtual hospital is because people understand Saudi now is always ahead of the curve. We used to be laggard. We used to be, we'll take the medication 20 years after it's out. اليوم لا. مثال حق hepatitis C, we were the first company to do a national adoption. Similar with technology. So for us to be able to really support, imagine being able to do a life-saving cath remotely. I played with the device. It's great, and it was designed to do all the advanced maneuvers that an expert cardiologist could do, wiggling the whatever, a lot of things. So I think, yeah, you're right. But we're clear. If it's a dark side, if you're not covered fully, you're out.
Thank you very much. It's really very interesting lecture, mashallah عليك. Just want to ask about the regulation of virtual hospitals. It's going to be only under governmental sector or private sector can work on it?
Our goal is to make it available for everybody. Our goal is to streamline access to care no matter where you're coming from. We have mandates to also participate in global coverage. It's one of the strategic KPIs that I have to comply with. But we do it as in a way that really doesn't change the process, because having a lot of variation will not make you succeed. اليوم ما عندنا أي تعاقد مع بس this is in the core of our objective. We want to start with other government sectors, and privates are welcome from today. Maybe, as you mentioned, regulations are not, but yeah. الله يحييك، نتشرف والله. خلاص إن شاء الله. الله يحييك، أبشر أبشر إن شاء الله. شكرا.
الله يرضى عليك، اكتب لي التعريف اللي وانا نكتبه في تويتر عنك، لانه كتب الدكتوره عائشه غلط وزعلت. يا محمود تفضل بس اكتب لي
You
التعريف.
can have your break and we will go. We will come back at 10:45. Please, thank you. Enjoy your break.
تعال تعال. احنا فين قول لي عبد الاله فين احنا؟
بس مدير الطبي التنفيذي، مدير الطبي مستشفى
مستشفى ايش يسموه؟
صحة.
Okay, welcome back again. Now we have a presentation of national home healthcare standards. Please let us welcome Dr. Sultan Al-Houti. He is a consultant family medicine. He is a member National Home Healthcare Committee. He is a vice president of Family Medicine and Community Society. Consultant of Standards and Development Accreditation. Please let us welcome Dr. Sultan Al-Houti.
Dear scientific committee, dear Fakeeh group, dear my colleagues at National Committee of Home Healthcare, dear speakers and attendees, Assalamu alaikum wa rahmatullahi wa barakatuh. I'm very happy to be here before you to speak about a beloved topic for me, national standards of home healthcare. I will speak about these topics, inshallah, the following slides. Before that, I have a question. Is providing high quality home healthcare service difficult? This is the one. The other one is getting Sibahi accreditation difficult. So we think of accreditation like World Cup. I believe that most people like me have post World Cup depression. We need to be treated for that. So here in Sibahi, we are taking place of Saudi League, Saudi Team League. We are challenging others to providing the best quality they can do it. So we beat them in the beginning. Maslahatum. Then, if they take it seriously, sorry. أنا صار عندي بطيء هذا شوية البوينتر يا شباب. يلا حماس ما وش صار بعدين يا جماعة ما ندري. طيب أيوة ممتاز. So if they get يعني manage to deal with this standards, we will give them best, you know, and World Cup. In our case, the best and World Cup. يا جماعة إيش الدراما هذا وش البوينتر؟ Our accreditation certificate. So we are welcoming everybody to enroll in Sibahi and get the accreditation of Sibahi. So I'm feeling obligated to speak about Sibahi. So we are the national standard accreditation body in Saudi Arabia. Our aim, our mandate from the Council of Ministries to develop standards, assess and survey support toward accreditation, granting accreditation itself, and maintaining and following up with the healthcare facilities to have their accreditation. So, هي يعني جماعة الخير I'm struggling here يا جماعة الخير. Sibahi not like that, huh? Sibahi not like. Sibahi experience is better than that, يا جماعة. So this is our beautiful building in Riyadh. And of course, everyone knows what's accreditation. It's a formal process set by independent organization to maintain other healthcare facility, you know, accreditation after fulfilling these standards.
Yeah, it's a part of excitement.
So I believe it's good to bring green tea. So we are maintaining the accreditation for 3 years. Usually this is our cycle. And let me speak about our logo. We just updated our logo recently, if anyone noticed that. So we have this 4 samples. We integrated in one sample. So we have Red Crescent Healthcare sample. And we have I. In Sibahi, we are saying that we are I on quality on healthcare. And we have our stamp of accreditation. Lastly, we have our beloved palm that fruitful all over the years. every time our Saudi emblem, we integrate it together in this beautiful, hopefully beautiful logo. So our vision is to be #1 healthcare accreditation agency in the healthcare and the region, of course. And our mission to support all healthcare facilities to get accreditation. So we're working with healthcare facilities to take accreditation. And we are honored and proud to have the triple award from ESQA, International Society of Quality in Healthcare. So what's ESQA? It's the accreditor of accreditation bodies. So as we make you, I don't know, wallah, I don't want to say it any. For some people think that Safar from Sibahi, we have the same thing. We are drinking from the same cup from ESQA. ما يحتاج. So let's speak about the our estimated market size. 35 million people, Allahumma zid wa barik. And we have تقريبا 13 administrative regions. We have diverse topography, for sure. And it's a content of 2.2 million kilometers. So we have almost 500 hospitals. I'm speaking in the private and public sector. And we have almost 2,500 ambulatory healthcare centers. We have also a 300 clinical lab and blood banks. We have almost primary care, almost the same of the ambulatory care, and the numbers are increasing. We have almost 300 home care service, and we would love to see more and more numbers, especially for home health care, since we are speaking about home health care today. And for dentals, we have almost 1,000 centers. So if we put that together, it's almost 7,000 healthcare centers, each one of them requiring a special set of standards and individualized visit to survey their performance against our standards. So Sibahi, having these 3 pillars: standards, survey process, which is the assessment tool that used to survey the standards, and surveyors, our army who can survey the facility against our standards. So, first thing, how to register with Sibahi. Just by Google Sibahi and tab on this icon, healthcare facility registration form. Following this, Dr. Mirfat, she asked me, the Fakeeh group wanted to be the first one who getting Sibahi accreditation. So it's easy, just please follow these steps. By following these steps, welcome in Sibahi portal, and then inshallah things will be better inshallah. Little spicy, but better inshallah. This is the accreditation journey. Basically, we have 3 phases. We have the pre-visit, we have during visit, and post-visit. So pre-visit, which is the registration with Sibahi, contacting, Sibahi contacting the healthcare facility to arrange the visit agenda and the date and all of these logistics. And during the survey visit, what will happen is that our surveyors will go to the healthcare facility and they will try to measure the performance of the facility against our standards. Post-visit, which is the decision taking after reviewing the surveyor's report and after checking all the elements that healthcare facility. I would like to clear something here that when our surveyor is visiting the healthcare facility, we have a set of standards that need to follow, okay? But if they notice anything outside of this standards that affecting the quality and patient safety, they will label it. They will mark it, and we will take it seriously in our decision of granting accreditation right. King Fahd Fountain. بصراحة يعني كانت دراما، بس كنت أمس أمشي في الكورنيش عشان بستمتع بمنظرها. للأسف كانت مقفلة. Anyone noticed? Yesterday was their, annual maintenance day. So yeah, coincidence happened. So King Fahd, can anyone tell how old is King Fahd Fountain? 40? Yeah, it's younger, Look, mashallah, look closer, it's younger than that. It's 37 years old. 37 years old, and one of the highest fountain in the world. It's reached to up to 312 meters. So mashallah, and still mashallah, one of the landmark of Jeddah city. So let's speak about our business, Let's speak about Sibahi accreditation for home health care. So we have general policies in the first two folder of the book of Sibahi, and we have 5 chapters. Each chapter speaking about different element. We will tackle it inshallah a bit. We have 54 standards, and we have 234 substandards, meaning that we have 234 elements, scoring elements. So we're assessing in 2, 3, 4, data point. Dr. Maher لقيتها الحمد لله. Revenge. طيب, this is the chapters. So anyone want to have Sibahi book, just please scan this QR code. So we have leadership of the service, we have provision of care, management of information, infection prevention control, and facility management. We'll speak inshallah about it. So leadership of the services is 26 standards, speaking mainly about the organizational structure, patient family rights, human resources, risk management, and quality improvement, and patient safety. I put some examples for you. This is the first 4 standard. Sorry. 4 guys sitting there comfortably. I'm suffering with this, just to state it. كنتم من قبل الله يكون في العون. So, to know more about the standards, about the others, please, you can just scan the QR code. So the first one is the governing body defines its structure and operation responsibility in written documents. We have, of course, substandards helping people to fulfill these standards. And the rest, as you can read it here. And for provision of care, it's 12 standards. So speaking from the access to care, ending with discharge patient from the service. Tackling, of course, patient and family education, identification, medication management, and patient assessment and treatment planning. And again, here is some examples. So patients have access to home healthcare service based on their health needs and available service, and they are registered to receive the required service. Of course, as I told you earlier, we have substandards supporting the healthcare facility to fulfill this standard easily, inshallah. The third chapter, consisting of 6 standards, speaking about unique documentation and completion, security, confidentiality, and record retention. Again, here's some examples. The home health care service defines in policy the information that needs to be shared internally and with other external entities and its format. The fourth chapter is infection prevention and control. It's 5 standards. And tackling the sharp waste management, reporting communicable disease, hand hygiene, employee screening and immunization, and lastly, personal protective equipment. The home healthcare service implement a coordinated program to reduce risk of healthcare associated infection. The 5th chapter, or the last chapter, is facility management, safety. And we know that home health care has a unique position in terms of providing health services. So it's basically providing health services, as all of you know, in the home of patients. So we understand that. For that reason, we put only 5 standards. This is a unique in Sibahi. We are caring about FMS, about having a suitable place for patient, for the staff, and for the visitors. So we ascertain that these standards, the 5 standards, are covering the security, medical equipment, storage, fire safety for the staff, and hazardous material and emergency. يعني لا سمح الله. This is the 4th standards. والله يعني I should put صراحة the 5th one so that I include it all, بس ما في مشكلة. So the leaders establish and support facility management and safety program. يعني we believe in Sibahi that quality is everyone's responsibilities. Every one of us supposed to take care, take part, and play importantly in providing and maintaining the quality of the healthcare service that they provide. Thank you very much.
Thank you so much, Dr. Sultan, for your interested presentation. Since your entrance with the champions and the Mondial, still fresh memory. Thank you so much. Let's move to other presentation. Let's move with Dr. Hamadi Rifa'i. She will present hospital at home. Dr. Hamadi Rifa'i, she is a family medicine consultant at home healthcare. She is an assistant professor in Taiba University. She is also a project manager of home healthcare services line in Medina Health Cluster. She is a leader of home healthcare services in Medina also cluster. She is a director of technical affairs and development in Medina Home Healthcare Directorate. She is a founding and a board member of Saudi Scientific Society of Home Healthcare. She is a founding and board member of Home Medicine Association in Al-Madina Al-Munawwara. She is a director of Saudi Scientific Society of Home Healthcare in Western Office. She is a DIO and program director deputy in Saudi diploma for Saudi diploma of home healthcare physician. Please let's welcome Dr. Hamad Rifa'i.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. هو البوينتر فيه مشكلة من أول. طيب حياكم الله. في البداية أحب أشكر الدكتورة ميرفت من الصديق وفريق العمل على الاستضافة والدعوة لهذا المؤتمر. Today we'll talk about hospital at home. شكرا. Today إن شاء الله I will talk about hospital at home. يمكن قبل كده الدكتور حمود تكلم عن موضوع الهوسبيتال ات هوم والفيرتشوال hospital in general. This presentation is about hospital at home and it's specific for hospital at home. And this term was coined for the last 20 to 30 years back, and it's gained its popularity after COVID-19 لسببين يعني صراحة. COVID-19 it's helped in the innovation of hospital at home, and also the hospital at home help in the management of COVID-19 patients. The term virtual hospital at home, acute care at home, home hospitalization, hospital in the homes, all these terms used to describe hospital at home. And there is the different models for hospital at home across all the countries. In this presentation, inshallah, we will discuss the answer of these questions. What is the hospital at home? How does hospital at home work? And what are the model benefits? What are the current evidence base? And how can we implement this service? So what is hospital at home? Hospital at home provide intensive hospital level care for acute condition that would normally require acute hospital bed in the patient home for short period through multidisciplinary team. هذا باختصار the definition of hospital at home. Acute hospital care at home program is different from traditional home health care that all of us know, that it provides skilled nursing care for long-term patients with long-term disability in his home through skilled nurses or other skilled services. So this is called the traditional home health care, and it's not a hospital at home. Hospital at home. أنا عندي مشكلة مع البوينتر، أتوقع البطارية. طيب. As I mentioned, it's not a traditional home health care. It's not enhanced primary care program. It's not for chronic disease management. It's about acute illness management. It may manage the exacerbation of acute conditions, but it's not for chronic disease management. It's not an enhanced primary care. Also, it is not intermediate care. It's not for acute conditions. It's not for management of stable patients. Also, it's not a daycare. It's not for ambulated patient or stable patient who can reach the hospital and he come to take one procedures or one service. It's not admission prevention. It's an alternative to traditional hospital admission. The key feature for hospital at home, the condition of the patient, it's for acute management. It's provide urgent access to hospital-level diagnostics like endoscopy, cardiology, and other laboratory investigation, point-of-care test, point-of-care ultrasound. It's a provide hospital-level interventions like oxygen therapy, IV therapy, IV medication. It's required daily input from multidisciplinary team. بمعنى إنه patients connected to the hospital or virtual hospital with 24-hour cover. Any urgent visit can be done immediately. Daily visit done for the patients. Also, it's secondary care level specialist leaderships, and this program is limited for short-term interval, usually from 1 to 14 days. So it's not for long-term patients. It's hospitalization for short-term, for 1 to 14 days. Hospital at home patients have equity access to other specialty anytime the patients need any consultation, any interventions. It will be done as this patient inpatient, not a home health care patient. How does hospital at home work? The structure of hospital at home is different from one hospital to another, but there is a common concept. Hospital at home care is well suited for medium acuity patients who need hospital level care but are considered stable enough to be monitored at home. It's well designed for patients with well-defined protocol like COPD, pneumonia, congestive heart failure, diabetes, cellulitis. These conditions have a specific protocol for management. So hospital at home designed for these conditions in particular, or any other conditions with a specific protocol. The patients require admission for one of the target illness is identified in the emergency department or ambulated site, or from inpatient. Staff assess if the patient is good candidate for the program using validated criteria, like the age group, the conditions of the patients, the condition of the home, the presence of internet, as Dr. Sultan said today, and if the caregiver is cooperative and well consented to provide this service. If the patient eligible and consent to participate, the hospital at home team evaluate the patient and is transported home often by ambulance. And this point is very important. The patient is evaluated daily by the hospital at home team. So the patient are not physically in the hospital. There is a virtual bed. This patient considered as inpatient. The patient is never far from the healthcare providers. They are connected to their care team through a combination of in-person visit, video visit, continuous biometric monitoring. All this service should be available during the acute treatment phase and 30 days after discharge. Coordinated hospital level care, physical visit at least once daily and 24-hour coverage, nursing visit once or twice daily, telehealth care team providing remote support, video connection, medical equipment, transportation, portable diagnostic services, ER visit, clinical standard and orders. The diagnostic studies and therapeutic cannot be provided at home. The patients will receive this service through a brief visit to the hospital, like CT scan, MRI, or endoscopy. If the patient is treated and stable for discharge, when the patient is discharged, he referred to his primary physician, not for the hospital or virtual hospital team. It's referred back to his primary physician. So what is the benefit of this service? A lot of studies done to support the benefit of hospital at home, and a lot of findings indicate that hospital at home Okay. And these studies show the benefit of hospital at home. Most of these studies are randomized controlled trials. It shows that there is an improvement of all of the value equations regarding outcome, patient experience, and reducing the cost. The mortality decreased by 22% in some studies. Inpatient-induced delirium decreased by 74%. Pressure source and other complications from inactivity also decreased. ER department visit decreased also, and 30 days readmission rate also decreased with hospital at home model. أيوة. Compared to inpatient visit, on inpatient admission. Okay, and most of these studies are recent studies and randomized controlled trials. Also, the patient satisfaction improved with the hospital at home, and the stress on the patient and caregiver also decreased by this model of care. The cost also decreased. Average hospital at home has 25 lower costs of stay when compared to inpatient admission. And these studies done in 2012 and reinforced by another studies in 2019, and it showed that the cost is decreased by 38%, and also the The hospital have fewer low value services such as laboratory orders, imaging studies, and consultations. All these services decrease, the use of these services decrease with hospital at home model. Okay, hospital at home during COVID, the COVID enhanced the innovation in the hospital at home, and also hospital at home improve during COVID period, reduce risk of exposure to COVID-19 patients. The remarkable expansion of hospital at home كانت 12 stand-alone care model in the USA before COVID-19, and after COVID-19 it's increased to 145. So this is a magic increasing, and it's mean that this service need to be applied in many facilities. Is your healthcare system ready to implement hospital at home? If the answer of one of these questions is yes, it means that we need hospital at home at our institute. Is your health system experience problem from lack hospital capacity? Does our health system establish home healthcare delivery capability? Do you have physicians with interest and ability to care of patients in the home environment? And this is a very important point. Does your health system experience large volume of admissions for common problems such as pneumonia, heart failure, chronic pulmonary disease? Does your institute view itself as an innovator for delivery of this model of care? Can your health system ally payment provide and the hospital for this models?
2 minutes more.
Okay. So before adopting home-based care model, health system must ensure that they have necessary resources, roles, organizational culture, and reimbursement models. In conclusion, this model is a logical response to changing epidemiology of acute hospital admission. Delivery hospital at home at a scale will require an investment in diagnostic infrastructure, novel training pathway, and broad cultural adaptation. Hospital at home offers a future profit alternative to current acute care model for this century. And this is some resources for hospital at home. And thank you.
Thank you so much, Dr. Hamadi, for your valuable presentation. Could you please just raise the voice? Okay, still we are on the same theme. We are talking, this is a refresh reminder for all of you. Still we are talking about the theme of the telemedicine. Another interesting theme, another interesting presentation by Dr. Hisham Al-Jarboui. He's a chief of geriatric specialty in Asir Province Health Directorate. He's a medical director of home care department in Asir Central Hospital. He's a medical director of COVID crisis and head of elderly medical department in France. He was. And also he's a member of Geriatric Scientific Society in Tunisia and KSA. Please let's us welcome Dr. Hisham Al-Jarboui.
Thank you. Bismillah wa salatu wa salam ala Rasulullah. Assalamu alaikum wa rahmatullah. Dear Fakeeh group, dear seniors, masters, colleagues, and all the audience, I'm here today to speak about the innovative telemedicine in home healthcare. I will not speak in a theoretical manner. I will talk practically. In fact, I lead in Asir scientific home healthcare innovative solution unit. We are in cooperation for sure with my professor in France who are specialized in innovating new solutions, using all the IT solution and what you called the future, but the future is now, is today the future. And recently we are in close cooperation with our new Scientific Society of Home Healthcare. And I want to thank Dr. Aisha Sir especially to create this very enthusiastic scientific society here in Saudi Arabia. So what I will present to you today is our, not a daily practice, but our test in south of Saudi Arabia to affront the daily challenges and to give you new solutions for the problematic of all the visiting team in home healthcare. Pointer. Okay. Everyone know the odd, our traditional triangle, which is based on a doctor, patient, and the family caregiver to elaborate a plan of care. But this is our vision of this model. We need to have expert home care, not only she's a traditional physician. We need to have our continuous monitoring and the synchronized decision to make in real time the right decision in the right way. And we want that our caregiver, even if they are family, they have to be skilled to arrive to some kind of professionalism. Is it an option now? For sure, no, because we have big challenges these days. First, the national home health care targets and the vision in KSA make us reflecting very fast and very smart to create a new solution for our isolated and confined patient who cannot arrive to hospital. Even the big problem we affront here in KSA, like said Dr. Walid Al-Kiridi first, the scarcity of experts. So what is the mean how to resolve this problem? Even we have other challenges in front of us, the numerous critical cases at home, the early discharged patient now, the new scope of service, and if I will speak about Asir region, you know the topography there, what I will say في معدل حياة مرتفع جدا. يعني ما شاء الله more than 50% of our patient, okay, then they are more than 100 years. ما شاء الله. So our tool used the first tool is the supportive scientific committees. Especially, like I said, first it's our home health care, the newborn scientific society. The miniaturization of devices make the solution more easy. The portable electronic file integrated system, the user-friendly system, and all the technological solution which make the problematic more easy to resolve. So we begin to work يعني على كل المتداخلين with the patient one by one. How to connect them and how to improve their quality of intervention or of decision with our patient. هي برنامج كبير احنا خططناه في عسير تقريبا for 5 years. ابتدينا السنة اللي فاتت وشغالين to test how to improve the quality of care, but ما تقدرش to implement all the IT system in one day, so we choose to begin step by step. What we did, you will see what we did, what we are doing now, and what we dream to do. We have the right to do, and we have all the opportunities here in KSA to do it easily, inshallah. We begin by the physician. If you imagine that you have one consultant who is leading a team of 10 or 15 doctors, under them there is 2,000 patients, okay? He cannot be everywhere, and he cannot follow all the his medical team. So the solution is to connect any visiting team, okay, to the main office. It can be assisted by any consultant, cardio, geriatric, ICU, to make the right decision in the right real time. With the point. This is a real test, and this is you can see even the monitors are transferred directly to the hospital, okay, and the consultant in the hospital will make the decision and will lead, not leading, but we try to robotize the visiting team. If you have only resident or not for example specialized nurse, so يعني ما عندكش مثلا اخصائيين في الجسم ولا كذا، عندك فنيين بس، اوكي، فني وريزيدنت. Even if the case is critical, you can by real-time connection, okay, you can make the visit more efficient, and the decision في مشكلة with the point. Okay. طيب, what to do to train your resident? في إشكالية إنه ما تقدرش تدخل على البيشنت with 20 resident, 15 nurse, okay, في some dignity for home patient, في some safety, okay. Any one of the team can خاصة بعد الكوفيد والريستريكشن اللي حاصلة، فما تقدرش تدخل بفريق فيه 15 أو 20، okay, but your resident, even especially now we are trying to have the home care, home health care as a medical specialty now, okay, so they have to be trained. The hospital will not give you all the approach of the home visit. So what to do? We reverse the roles, okay, and the consultant will be in the home, but in the amphitheater, all your residents في مشكلة with the pointer. For example, this is a real training. You are at home. يقدروا يطرحوا أسئلة، يقدروا يشوفوا، يقدروا يحضروا training كامل، okay, with a real patient, real visit, okay, but without being in the home of the patient. بعدين نقلنا سوينا التست مع النيرسز. For example, for the advanced dressing, في something which is called dermatoscope. Okay, it make full HD pictures, and for example, in our office we have one team who is specialized in the advanced dressing. Okay, you can see here they will make شو اسمه picture sent to your expert, and you can do also the reverse. يعني any nurse can do an advanced dressing assisted by the nurse expert or the plastic surgery surgeon, or and we worked like this method one by one. For the IV therapy also, a nurse team, was a real dehydrated patient. So if you send them with the adequate material, okay, you can have your blood investigation there, all the monitor, and our for example شو اسمه monitor for IV fluids, okay, they can make the right decision. They are more safe. They are more confident, your team there, okay? And even for the family, the decision is not made by عارفين كلكم الابروش مع العائله وكبير السن، مو زي ما تقول له انك الديسيجن ماخوذه من كونسلتنت او من استشاري او من الناس اللي تابعينه. فالكونفيدنس اوكي للتيم وللبيشنت وللفاميلي is very important في الهوم كير فيزيت بصفه عامه. This method of synchronized visit and assisted, it's done by all the experts. Physiotherapy also, it can be done by the same way. هذا is stroke victim, okay, who is followed up by our physiotherapist, and he is assisted by a consultant in rehabilitation and physiotherapy, and you will see التحسن السريع. في something we remark that any patient who feel to be assisted by distance, تحسوا المريض he wanted to show his strength, to show his performance. يعني الزيارة اللي فيها يعني closed ما بين البيشنت والتكنيشن, whatever he is the technician, for example physiotherapy, it's not like the visit when the patient feel that he is filmed and there is someone else or any audience who are looking to him. شوف البرفورمانس والسكيل تغير. No, not 5 minutes. طيب, I have to be more fast. هذا اللي سويناه السنة اللي فاتت. السنة هذه شغالين على موضوع جديد. I will pass quickly. نحاولوا نشتغلوا السنة هذه على الكير جيفر. خرجنا من البروفيشنال، اوكي، دخلنا الموضوع how to assist the caregiver at home. هذه الفيزيوثيرابي and بعد our future إن شاء الله. Even social support, he can be assisted by distance, and we try to create now group therapy by telemedicine. Okay, we connect 5 to 6 patients, for example, for the memory training or something like this. It can be done easily with our tools of telemedicine. What is our new project? Even here we are connected to the patient, directly to the patient. But our project now with Dr. Aisha is how to make the caregiver more skilled and more performed. احنا بيننا وبين الكيرجيفر ايش؟ عقد عمل. اصلا في الخارج يسموه not care plan but project of care. يعني بيني وما بين الكيرجيفر عقد. فيه الميديكيشن، فيه النيوتريشن، فيه البوزيشنينج، فيه التريننج، فيه health education. The problem that the relationship between the medical team and the caregiver is punctual. في نموذج ورقي كانوا شغالين بيه في اليو كي يسموه الهاو ار يو توداي بورد. هو عبارة عن بلان اوف كير كامل مكتوب ومعلق جنب المريض. احنا حاولنا نستعملوا some IT tools, okay, and we make it على السمارت فون. or better انه all the plan of care can be transferred directly على التلفزيون اللي في غرفة المريض. This project is done by Saudi engineers here, volunteers. Okay, we are the medical experts of the project. في solution جديدة عرضت علينا من فترة دكتور عايشة، عبارة على زي الريسيفر الصغير. الريسيفر زي بتاع البين سبار الريسيفر هذا it's connected to server. اوكي، وكل شفت شريحة التليفون نفس شغلها تقريبا. يعني الريسيفر هذا يتعطى personally to the patient, he's connected to his television and he's connected to our server يعني اللي في الهوسبيتال بالاي دي تبعه and you can send to him what you want. That means فيه synchronized and real time communication. فيها الميديكيشن، فيها alert system. يعني في مشكل ثاني whatever is the caregiver near the patient, okay, he can obey to the orders. يعني لو في ولد أو بنته أو الشغالة موجودة جنبه، لأنه مش تطلع له صوت وصورة مثلا اسم العلاج والفيديو اللي لازم يسويه في اللحظة هذيك. في كمان alert system. Our target that we will create with this one regulator software, which will correct all the mistakes even for the physician. يعني يقدر يعطي دواء الثيرويد يكتبه 10 بالليل، فالسيستم نفسه فيه ريجوليتر انه يصلح لك الخطأ مباشرة او في انتراكشن غلط او في والاليرت سيستم فيه كونفirmation من الكير جيفر عشان ما يجيكش في الليل يقول لك ضغطي مرتفع ترجع مباشرة تشيك على شو اسمه، لانه فيه real time and synchronized dashboard daily. It's repetitive daily, okay, but it can be regulated by the physician بدون ما يكون موجود جنبه. بطبيعة الحال فيه some kind of questionnaire in alert case عشان ما تكونش الانفورميشن اللي واصله من الكير جيفر فيري سبجكتيف. ففي questionnaire يعبى in case of alert to have an objective vision. على فكرة it can be also connected to camera and you have real hospital at home. هذا ان شاء الله الان قاعد في التستينج. صورنا لكم بس النماذج بتاع اللي كنا شغالين عليها واللي الان سوينا على 5 patient وان شاء الله نكبروا المشروع. This is our dream. This is our dream to have this integrated system with all the adequate devices, with the software which will like I said it make the auto control and the management of all the care plans اللي موجودين في شو اسمه يعني patient by patient, which is smart in this project انه لكل patient في care plan على مقاسه. لكن all these plans are connected in the same data. This is our future project ان شاء الله نتحدث عليها فترة لاحقة. ولو انه في واحد سعودي هذا شغال عليه الان بشراكة مع الصين. It's called the smart bed. smart bed اللي هو اللي يسوي شو اسمه هو المونيتورينج حق البيشنت. يعني تعرف البيشنت متاعك يجهز في بريشر ألسر او سوى كونفولشن هو في السرير ارتفعت حرارته نزلت. في alternatives كثيرة جاية. Okay, in the future, but like I said, the future is today. So we have to act. And I think that the opportunities here in Saudi Arabia are very promoting and very enthusiastic to be a model, really, especially in home healthcare. يمكن دكتورة عائشة تعرف أكثر مني ما هو شيء يمكن ليس اختيار ولكن الحاجة أم الاختراع يعني ما عندناش هنا فور اكزامبل اللونج نيرسينج كير ولا الالدرلي كير زي ما هو حاصل في أوروبا. أوكي في الهوسبيتال وفي الاوت اوف هوسبيتال. اوت اوف هوسبيتال is home care by excellence. Like I said, I think the opportunity in Saudi Arabia are very big to lead a home health care program worldwide. In the end, I want to say that it's not an option anymore. Home health care now have to offer quality of care and comfort of life now. الناس ما عادش تبغى العلاج وانها تشفى من جلطه وترجع تمشي. نو تبغى ترجع تمشي احسن من اللي كانت وتشوف احسن من اللي كانت واسنانها ابيض من اللي كانت قبل. Thank you.
Thank you so much, Dr. Hisham, for your interesting presentation. As you know, our life is so quick and the technology is affecting us, and we hope that the technology will affect and adding value in our home healthcare practice and operation. Now we are closing the session one, the theme one, as I told you about the telemedicine. So please, I will leave the floor for all of you to have any questions, so the speakers will answer to you. To whom you will start? Yes, I called them. I sent. Yes, please.
Assalamu alaikum. Amazing presentation. Thank you so much for sharing this with us. This is very ambitious and we're jealous. 3 questions. One is, how do you see the workforce design for the future home care? As you see, the scope is becoming bigger, the amount of information is larger, and the decision that we make is more complex. What's your input in the workforce design for that?
Thank you for our question. My answer is very, very easy. Like I said, the future is today. الفكرة لم نخترعها, but it's like a vision when لما تقابل حلول كثيرة في أماكن مختلفة. For example, the connected eyeglass and the IT system, I saw it because when COVID crisis, I was sent to South America. In French Guiana, كيان, تعرفوا كلكم القاعدة الجوية أريان. How the شو اسمه رواد الفضاء are connected to the base. And for any medical problem which has happened there, okay, شفنا لأنه كان البروفيسور معنا في الاي سي يو كان هو نفسه الميديكال دايركتور اوف ذا اريان سبيس سنتر. اوكي, فشفنا السولوشن اللي بدا يتعامل بها ايام الكوفيد كرايسيس. بعدين زي ما قلت تقدر تسوي شويه انالوجي مع other systems of home healthcare scopes in other countries. Like I mentioned, I worked in 4 countries, so I saw a lot of problems and a lot of innovative solutions. But the time now, it's an obligation, like I said. Okay, you have to be the number one, or all the world will pass you. Thank you.
Yes, please.
Dr. Well, I'd like to thank all the speakers. Just my question to Dr. Hisham. Dr. Hisham, I mean, do you really utilize this video conferencing for every patient? And how do you justify it that it's not a double work? I mean, if you have a certified nurse that is going to do some wound, why should she call, the call center and show them what is she doing? Isn't it a double work?
No, it is not a double work. Like I said, the first problem in home health care is the scarcity of experts. So we had the obligation to be everywhere with our teams. This is our daily problem. If not, you have to assist all your teams by phone, by WhatsApp. They will send to you photo. You will make decisions. Sometimes the caregiver will send to you the photo, and you will promise him about another visit, and you have to assist the nurse or the medical visiting team with the adequate material. You will wait for his feedback. Okay. To for example, to adjust or to do any regulation. No. Like I said, we are testing. We are testing one by one. ما شاء الله عليكم كلكم بس تذكروا عارفين انه في مجال البحث العلمي ما في حاجة اسمها you implement from the day one. Okay, we have to test. We have to present the solution. وبعدين سلطة قرار تفعيل مثل هذه البرامج لا ليست من مشمولات الأخصائيين الميدانيين. هو قرار إداري بامتياز.
طيب ممكن السلام عليكم. طبعا first I would like just to comment on the virtual clinic. We have an experience maybe now even before COVID. 3 modalities of virtual clinic. Virtual clinic direct with the patient and the caregiver. Second one as shared consultation when the nurses go with the physicians or with somebody need. And the third one is what we call a shared virtual clinic approach, which for example, if we have diabetic patients, so physician, dietitian, whatever, if we have a stroke patient, BT, rehabilitation, and etc. And in fact, still is not, I cannot say it needs more time and more experience to go on and to be successfully, especially it needs more training, for vocational training for the multidisciplinary team. My question, Dr. Sultan, thank you, Dr. Sultan, for the standard. But I am wondered, I know the JCI home health care standard, which is a bit different from the Saudi or Sabahi. But do you take in consideration chapters for a caregiver training and some random visits for the patient house to ensure that the safety in the house is the safety of the house as seen in your chapter? Did the team will go and visited some of the patient house? Thank you very much.
Thank you again, everybody, for being here today with us. And thank you, Dr. Salim, for this good question. Actually, in Sibahi, our philosophy is to include every stakeholder in developing standards. And we love to say that Sibahi is accommodation for all healthcare sector to be involved with us, to set standards together that fulfill our needs. So in Sibahi, we are thinking always internationally. We review all the similar standards if there are any available, and then we tailor it based on our national context, taking care of our values, our culture, and these things. So when we set the standards for home health care, we considered all the applicable aspects, taking consideration that what can our surveyors do it. I believe it's difficult a bit to visit every house to check the service provided in home healthcare. So we need to have something at least random to check the standards is applicable, and it's done. Our philosophy also that the standard is RUMBA, meaning that it's relevant, understandable, measurable, beneficial, and of course achievable. So thank you for your great query, and yes, we are taking in our consideration that to have random home healthcare visits. And actually, to be honest, totally honest, we're still in the process of developing the survey process of home healthcare. So we are, open up for ideas, for thoughts, for queries, all of that to put it together, inshallah, in our final product that's serving our population. Thank you.
Thank you so much, Dr. Sultan. Yes, again, guys, if you have, please, any question, just put it in your paper, and we will just pass by the mic so you can.
Thank you, Dr. Sultan, for your presentation. But I'm representing here a department who will try to have the CBI accreditation. So my question is very simple. What's the difference between the GSI and the CBI accreditation to prepare ourselves? Second question is the technological solution are considered in CBI. Thank you.
Thank you again. First of all, I'm very sorry, صراحة, that I'm giving the people asking question my back. Sorry, but it's designed this way, and we make sure in Sibahi that our process is easy to follow and doesn't represent that to give people their back. So, based on your question, what's the difference between GCI and Sibahi? Actually, there is varies, different, a big list of differences between GCI and Sibahi. First of all, GCI started in US 70 years back, while Sibahi started in Saudi here in Jeddah, especially 10 years back. So GCI have this aggregation of experience, while Sibahi, it's a young institute driving to change and running very fast to catch up and to be a very important institute in our great transformation in healthcare. Sibahi focusing on the national context, as I said earlier. So we take care, we are involved, we are aware of the international standards, different standards, including GCI and others, but we tailor it in our local context. We need to have the best of the best in our market. Okay? This is the first question. The second question, you say that is Sibahi taking care of technology? Yes. Okay, advancement. Yes. I believe it's a must, It's not a luxury to take care of the technological advancement anymore. It's not a luxury. It's a must. We need to be aware of our context, as I said. We need to keep up with things. We need to start from where people ended, rather than to start, all over from the scratch, over and over. I believe that everybody here, who joined us today, thank you, Sarahat, and thank you very much for your attendance. That's reflected in how you are interested and playing a major role in improving healthcare. So we need to take care and we need to be responsible. Let me finish with this saying. In Sibahi, we are pleased that we are, but never satisfied. We are working for more and more. Thank you.
Thank you so much. One more question.
For Sibahi, sorry again. We are in Fakeeh Home Healthcare, the first facility in private sector to get GCI twice, and now inshallah we hope to be the first Sibahi also accredited. My question, do you have one surveyor like GCI covering all the standard and all the chapters, or more than a surveyor in the survey process.
I would like to thank Dr. Maher. جزاه الله خير. يعني he keep giving me يعني المايك over and over. الله يجزاه خير. And ما شاء الله يعني seems he's expert with that since he's a consultant ما شاء الله in rehabilitation. So yeah, he's looking for part-time job in Fakeeh since it's looking for the first accreditation. إذا ربي رزقك عاد لا تنسانا. طيب it's very great والله. It's very great. I'm happy and thrilled صراحة to hear that. About يعني Fakeeh achievement in getting GCI ما شاء الله multiple times, and I wish صراحة best of luck for all healthcare providers, especially in home healthcare. And yes, in Sibahi we are صراحة يعني we are very keen that to make the standards reachable, achievable, as we said. يعني we don't tend to challenge healthcare facility to get standards. لا, this is not our way, and this is not our aim. We tried our best to make the standards reachable, and you need to play or take some effort to reach it. It's not a challenge anymore. And hope يعني I wish صراحة best of luck for Fakeeh to get the first and to keep يعني with the first thing ما شاء الله تبارك الله. And we are in Sibahi يعني كلنا يعني أبواب مفتوحة وعيون, since we are, I say that Sibahi is eye on the quality, كلنا عيون مفتوحة for you. Thank you.
Thank you so much. Good. And this side, do you have any questions? The appreciation, it's our responsibility, and I will leave the mic for Dr. Wasim.
Thank you all our prestigious speakers for a wonderful enlightenment upon the first session in our symposium today regarding the telemedicine, meaning, challenges, and all the future vision of home health care and telemedicine. Last but not least, to close this session, we would like to honor our speakers and thank you. This is gonna be less than you deserve, but this is the least that we can do. First of all, we would like to thank Dr. Aisha Sghayr for her speech on prevention as a pillar in home health care. You may come, please, Dr. For his presentation and speech upon the virtual care at home, Dr. Abdulaziz Al-Hmoud. Dr. Sultan Al-Houthi for his interesting speech about the national standards of Sibahi for home health care. Dr. Hamadi Rifai for her speech upon hospital at home. And Dr. Hisham Al-Jarboui for his speech on innovation in telemedicine. And we'll not forget Dr. Walid Al-Kredi for his interesting presentation about the future in home health care. Yeah. Thank you all. Appreciate your time. You may go to the buffet area for the lunch break, and inshallah we will get back at 1 p.m. Thank you.
هذا يعتبر second session ولا third session؟ second ها؟ هذا session ايوه تيلي اي نعم ما كله تمام. هنختصر الوقت بدل 20 دقيقة، هنعطيكم 20 دقيقة 20 دقيقة، كل واحد 20 دقيقة. أي بس الدكتورة هتجزء. خلاص؟ طيب. السلام عليكم ورحمة الله وبركاته. Would like to welcome all the audience for the second session of Fakeeh Home Healthcare annual meeting or symposium. I would like to thank the scientific committee. I am honored to introduce our first speaker. First speaker for this session is Dr. Hana Al-Uthaymin. Dr. Hana Al-Uthaymin is a nursing director of home healthcare at Al-Medina Al-Munawwara home healthcare sectors. She is a program director of advanced diploma of home healthcare, which will be conducted for the first time in the kingdom. Dr. Hana have a lot of research in the nursing, especially in home healthcare. The topics of Dr. Hana will be new era of nursing and home healthcare. Dr. Hana, the floor is yours.
Thank you, Dr. Salim. Assalamu alaikum. Thank you, Dr. Salim, for your introducing me, and thank you for all the participants and all the speakers and all the attendees. Thank you, Dr. Mirvad bin Siddiq, to let me to have a chance to introduce my presentations about nursing in this first Fakeeh International Conference. Okay, I am Hana Al-Uthaymin. I'm a nursing director of home healthcare administrations and also a program director of advanced home healthcare diplomas from the Saudi councils, and also a program director of the Meccan home healthcare nursing. And I have a lot of membership in home healthcare administrations and also in regional nursing administrations. This is the outline for today. We will discuss about we will take a view and introduction about the nursing in home healthcare. We will discuss the overview of nursing profession and the home healthcare nursing also. We will have the importance of the nursing in home healthcare settings. And also we will discuss the scope of the services in home healthcare. And I have searched a lot in this aspect. And also we'll discuss the classifications in the home healthcare nursing and other specialties. And also we'll have a future of home healthcare nursing and the recommendation of our presentations. At the end of this session, inshallah, you will have these objectives. Okay, the demand of the home healthcare is predicted to grow and increase gradually, okay, over the coming decades. The reason for these demands is the dramatical change and increase of the average life expectancies within a number of people aged over 60 years. About 58% of the general populations in the USA have been shown that about their age also about between 50 and more, they have shown to prefer the service to be provided at their homes. The highest percentage of the patient who use the home health care are elderly. As we know, most of the service are providing for elderly patients at home, but it's not restricted to home health care elderly patients. The number of the people aged above 65 and older is projected to grow gradually and nearly will be in Saudi Arabia 1.5 million in 2050. Due to this increasing and growing number of older patients, the home healthcare services are expanded rapidly to meet the need of the growing elderly populations and those who are suffering from many chronic disorders such as hypertension, diabetes, cardiovascular diseases, which need preventive, curative, and rehabilitations. The same issue, the pointer. The home health care have an impact on improving the quality of life among the elderly patients in home health care settings. Also, the impact of the wound in home health care have been improved to 89% in home health care services. Is the nurses important in home health care? For sure. They are the core of the healthcare systems, and nurses are the front line of the healthcare systems and play a significant role in the provision of health services in hospitals, in a home care, even in a community, even in a school. They have a role. Around the world, the shortage of qualified nurses is one of the critical challenges in the field of the home health care, and it's a multi-phased phenomenon. Globally, the healthcare system are facing the crisis of workforce nurses shortage. According to the WHO and the International Council of Nursing and Nursing Now, they stated that there is a global shortage of nurses, about 5.9 million nurses, and the greatest need are in South Asia and Southeast Asia and Africa. In European region, 7.3 million of the nurses and midwives have been prepared and employed. However, this number is not adequate to meet the current and the future need. Nurses is a dynamic profession subjected to rapid change in the healthcare provisions. Home healthcare nursing is a specialty in which nurses, they provide a multi-dimensional home care to patients at all age, not only for elderly patients. The home healthcare nursing is intended for clients who are still required some skilled nurse personnel to assist, initiate, and oversee nursing interventions. Despite the growing demand of the home healthcare nursing, there is a growing home care force shortage. Some of the reason for this shortage is the focus on the hospital need. If we went to any hospital directors, if we have nurses and we ask them that we have a shortage in a home health care and also we have a shortage in the ICU, they prefer to put the nurses to the ICU bed, not for the home health care bed. Also, the hospital-centric nursing curriculum leading to undervalue the home health care settings. The home health care nursing has multiple meaning around the world. In some places, it's the provision of skill and professional nursing care in the home, or it's provided by the family member as a caregivers with teaching and support by hospital or clinical-based healthcare providers. What is the importance of the nursing in home health care? What they are doing? They assess the health situation for each patient. They assess the home environment to have and to let the patient to be in a safe place, to check, as Dr. Aisha and the other respected speakers discussed early morning, also to help the patient to regain their health and well-being. Also, post-operatively, the nurses have a role after discharging from a hospital. Also providing care for bedridden patients and those with bed sores, Even they have a role in detection and early assessment and frequent assessment of the patients to help them to be as a well-being, in a well-being, not to have or develop a pressure ulcer. Also, they have a role in care for patients who discharge from intensive care units. Also, to provide a palliative care for cancer patients and also terminally ill patients, nutritional advice for patients and elderly patients on a tube feedings, and not only in tube feedings. Even they can advise the patient who is old age patient and have difficult swallowing, preventing them from aspiration or any other kind of nutritional advice. Risk assessment and identification management of patient-related risk, as discussed in the early morning, reporting and analysis of the incidents, and the capacity to learn from the follow-up on the incidents, and implementation of solution to minimize the risk from occurring. Also provide a support for the health education of the patient and their caregivers. What is the scope of the service nurses can work on? Let's take a look over it. The scope of the service, the nurses have a role also in promoting health and chronic disease management, such as hypertension, cardiovascular diseases, and other diseases also. Medication administrations. Medication administration can be given by the home health care nurses. Also, educating and monitoring the general health of the patient. The nurses have to assess the patient during the home visit. They have a role in the home care. Pediatric home health care also can be provided. Psychiatric, palliative and controlled of narcotic medication, and also chemotherapy. In some of the region and all over the kingdom, they provide chemotherapy at home. Wound dressing and ostomy care. The nurses have a big role on these wound dressing and ostomy care and prevention before curing or before discussing the wound and how to put, even if it is classic or advanced wound dressing. We have to assist the patient to prevent from developing any kind of wound. Intravenous therapy also have been shown some of the home health care settings. They provide those services. Pain control and catheters also care, such as Foley catheters or NGT. Those scope of service, I have wrote it after reviewing private and governmental and other sectors for home health care. Also, if we went a little bit advanced, we'll see the hospital at home, the nurses have a role on it. Hemodialysis at home, as have been discussed in the early morning. Antenatal and postnatal care, as shown by Dr. Walid in the early morning, that it's one of the finance or economic report of the kingdom. Also, post-operative care can be done by the nurses and can be one of the scope. Well-being also can be one of the scope of the service the nurses can provide. Hormonal enzyme replacement therapy at home, it's also one of the scope. Sleep test, vaccinations, if it is for the pandemic like COVID vaccines or other vaccines also can be given, such as influenza and tetanus and whatever. Other scope of service, maybe the nurses have a role and may not. Dental care, diagnostic care also, occupational and speech therapy, Holter care, lab investigations and PCRs, also the sleep test, physiotherapy, respiratory therapy, and nutritional therapy. After all those scope of services, what is the classification of the home health care services? We have a skilled care nursing home, which provide a general care to the patients. We have a chronic care, the nurses who provide care to patients with chronic diseases. Also the advanced care, as we discussed, like a hospital at home, like a hemodialysis nurses or chemotherapy nurses. Also the health promotions and vaccination. And we have another, but it's not nursing, non-skilled in home care. We will discuss the skilled and non-skilled. Skilled nursing in home is a high level of medical care, such as the registered nurse, licensed practitioner nurses, and certified nursing assistants. They provide care for wound, for intravenous, injection, and catheters. The supportive home health care, which we call it non-skilled, or including the social care, and also it's a non-medical services. We can say it in other words, it's a home care provided assistance to everyday needs of the patients or elderly patients. John Hopkins have an example to provide specialized services like a memory care and other like fall prevention program and emergency preparedness and home safety evaluation. The home care focuses, the memory care focuses on teaching how to help people who have a memory loss or Alzheimer's disease or other type of dementia and personal care. Nurses also can step after all those scope of service to be or have a role as a case managers, meaning that they coordinate the service from different disciplines for patients such as rehabilitations, pharmacies, and for the other healthcare providers. And may also they must provide up-to-date and effective care for the patients, which is also a very important part for home healthcare nurses' job. What is the future of the home health care? The future is to shift to high-value home health care will grow, to importance to deliver uniquely patient-centered care at home. Nurses are the core service of all healthcare, and also they are the key component of the home healthcare services. In contrast to the growing needs of the home healthcare nurses, and nursing education is predominantly focuses on the preparation of the nurses for hospital setting, not for home care settings. Il pointer ترى. Okay. Yes. Home healthcare nurses must depend on evidence to guide their practice, and yet there is a very limited evidence for practice as well as lack of educational to prepare home care nurses for best practice for management of home health care services. While nursing is the most important provider in home health care, there is little evidence on what home care nurses need to better support their practice. What is the future of the home health care nurses? We have to generate and use the evidence-based practice guidelines for home health care nurses. We have to redesign the healthcare systems. We have to develop leaders for the home health care at all levels to create community health and home health care services. Also, another aspect we have to consider it is to use the skill mix nurses. What is skill mix nurses? Is the number and educational experience of the nurses working in a clinical. We have to make sure that we have optimal staffing from number and skills. And there is a lot of policy attention have been paid about the importance of the nursing skill mix on a healthcare delivery. If we have, is it enough to have a skill mix only? No, we have to have a safe staffing and a skill mix. Safe nursing staffing is mean that we have a mix of education, skills, and experience for nurses, and we have to invest in a safe and effective and needs-based nursing staffing levels to be cost-effective. What is the recommendation of this presentation? We have, as a nurses educator, the nurses educators and university must redesign the existing educational program and curriculum to meet the growing demands of the home health care. Recently, just before 2 years, they have launched an advanced home health care diplomas, but the seat is still limited to fill this demand. Also, innovation in education that focuses on filling the gap is the evidence base for community nursing practice and home care nurses. Improving access to continuing education and evidence-based resources for practicing home health care. Also, save and mix nursing staff are the key component of the home health care. Also, the last recommendation is more researches on the home health care nurses, work-life, staffing, and the needs of the home health care nurses. And this is my reference. And thank you if you have any questions.
Thank you. We'll keep the question and answer after. Thank you, Dr. Due to طبعا some emergency, so we'll postpone Dr. Walid, Dr. Maher presentation. But again, I am honored to introduce the Dr. Adil Siraj. Dr. Adil is a senior consultant, psychiatrist in Fakeeh care. Dr. Adil has very extensive experience in psychiatry, more than 30 years as a clinical psychiatrist, and he has a lot of research experience and publication. Topics of Dr. Adil will be quality of life for psychiatric illness and home health care. Dr. Adil.
Thank you, Mr. Chairman. Thanks for everybody sitting here. Sorry for this technology problem. Bismillah ar-Rahman ar-Rahim. Disappeared.
We opened it already. كان مفتوح أول. يمكن دكتور ابدأ.
هو موجود معايا على فلاش ميموري، احنا لازم نشغله.
ما في مشكلة، أحسن فلاش.
محسوب دكتور عادل الوقت كيف
بسم الله الرحمن الرحيم. Inshallah, my talk will be short, precise, from my personal experiences in Fakeeh Hospital. I will share you some stories I lived in Fakeeh Hospital in home care psychiatry, and I will show you what is the trouble we are living in and how things are not easy for us. For psychiatric home care is absolutely different from other home cares. Mental health care is delivered in patients in their homes, unable to access clinic-based services or office-based services. This is necessary to continue and maintain a comprehensive plan of care. This care is only available for homebound patients. Homebound patients is a patient whose medical or psychiatric condition limits their ability to safely leave home without assistance and supervision of another individuals. And sometimes the psychotic patients, they refuse to go to see a psychiatrist. And they say they have no insight about their illness and they don't ask for help. Typically, the patients has a very poor support system. Also, some patients, they have a very poor support system. Within the community, no family or interested family members or supportive organizations have a poor understanding of psychiatric disorders. Yani, no one supports someone to visit the patient in home and to give him or her this clinical and psychiatric services. Services may include drugs, assessment, diagnosis, and drug administration. Schizophrenia management, I will talk about four or five cases in our spectrum in psychiatry, just to show you how home care can help and what is the situation we do face. Schizophrenia management as a part of home healthcare service. Schizophrenia destroys patient's life from the family. The family becomes broken. The occupational record deteriorates. He loses his job, he loses his family, he loses his mind. And to approach him as early as you can is something very difficult, because there is denial by family members, there is denial by the patient himself that there is an illness behind. I want to show you a piece of drama just to close up your mind how things we are. Okay. This is 1 minute drama from Beautiful Mind movie. This is Professor Nash, Nobel Prize winner.
Correspond to singularities.
He has his Nobel Prize in 1994. For work was done in 1940s while he was a student and professors in Harvard.
Relativistic exploration.
He was very much paranoid, hallucinating. To catch the patient in home is not easy. You cannot see the patient. Go to him at work. I catch a patient in the street because he was wandering. He never goes back home.
Sometimes our expectations are betrayed by the numbers. Variables are impossible to assign any rational value.
This is sometimes in presentation, in art of presentation, it is called the fatal attraction, because you remember the movie and you will forget everything about the presentation.
So, we see.
راحت تاني. هات الفيديو تاني. Okay.
So,
he is giving the lecture, and the psychiatrist and the nurses, the male nurses, are accompanying him to catch the patient to the hospital.
In space-time, singularities in space-time, then, and conventional number theory, it breaks down in the face of relativistic exploration.
Here is the psychiatrists and nurses. He taught them that they are spies and they are Russians and they are going to invade America. This was his paranoid system.
Sometimes our expectations are betrayed by the numbers. Variables are impossible to assign any rational value.
This movie, Oscar and Russell Crowe had Oscar for this acting because he lived with a schizophrenic patient for 3 months and he met Professor Nash to imitate all the words he says and how to walk like them. Professor Nash!
Professor Nash? Professor Nash? Let's avoid a scene, shall we?
What do you want?
My name is Rosen. Dr. Rosen. I'm a psychiatrist.
Forgive me if I don't seem persuaded.
I'd like you to come with me, John. Just for a chat.
Appears I have no choice.
This is very easy for a psychiatrist. You must be beaten.
Help me! Somebody! Somebody! Help me! Help me! I know who you are! I know who you are! No. Charles! Charles, the Russians! Charles, the Russians! Help somebody! Help somebody, Charles! The Russians!
Steady the leg.
Get away from me. Stay away from me.
All better.
1940s. What's actually?
Everything's all right here.
The only. No, I just. Okay, I just want to close up your vision. What is a psychiatrist can do when he is for home care and what he can faces. This is one of the very high risk missions we do face. And we cannot say no. I will tell you other stories without pictures and without drama, but maybe more painful for me than this. And many things happened more than this. أنا خايف أمسكه بقى. Okay, I will show you. Can we play the video? This girl, the parents came because they said that their daughter is about 33 years. She is 5 years sitting in a dark room talking to herself. She has a daughter, 5 years old, and she is divorced like a scary movie. She never bathes. She makes toilet anywhere. She speaks to herself, and she has spontaneous laughter, and she laughs to herself. Another 33 years old female patient, divorced, has 5-year-old girl. For the last 5 years, she is locked in her dark room, self-talking, spontaneous laughter, screaming and yelling irrationally. I visited her with a nurse, and we checked the villa. Where is she? The bathroom down, the bathroom up, the kitchen somewhere. Then we heard some little voices somewhere very dark. She was sitting like this, and both of her parents are very, very afraid of her. They cannot touch her. And they warned me, take care. She is carrying knives for anyone to come. She was about 33 kilograms, severe malnutrition, and severe dehydrated. And to my surprise, how the parents were tolerant to leave their daughter like this. 5 years, sheikh coming, sheikh out, sheikh coming. She is mashed, she invited, mahsuda, fi ain, fi hasad, till someone sheikh said that it could be a psychiatric illness. Ask a psychiatrist. We diagnosed the case, and we said that I did too much effort to convince the parents that she is schizophrenic. And she is deteriorating for neglect of care. And she did not receive treatment. To my surprise, it was the first time for management and first time to take medication after 5 years like this. She rapidly responded, and she started to be aware, and her hallucinatory experience absolutely ceased. Her husband, when he came and he saw her like this, he did not believe. And I met him, and he restored his wife, and he restored her daughter back. 1 year later, when she is fully recovered and she went her home, her father said that the magic disappeared, but it might come back. It was magic. It was not psychiatric illness. Yes. Whatever you do, it was not. It was. She was mashed, and we are sure she was mashed. We have to make some psychoeducation, and this is the locked-in patients. They are locked like this because of the family denying this history, even if you showed them the alternative. The alternative in this case can never be in office, can never be in clinic. You must be there, you must be with them, and you must show them there is alternative, and you must show them that you can deal with these patients and you can have a management. Evaluation of home care treatment of schizophrenic patients, several studies have been done, and because our patients usually they do refuse the medication, we have a monthly injection, 3 monthly injection, and nowadays 6 monthly injection. Great breakthrough. This was a dream when I was recently graduate. We had only oil injections and it was full of side effects, but now, no, the situation is absolutely different. 1 monthly injection, 3 monthly injection, 6 monthly injection. So you will visit the psychiatrist twice a year, just for evaluation, assessment, and take the injection, and this will act for long acting to cover him and to treat him from his hallucinatory experiences. What you saw in the drama scene, that the schizophrenic patient is listening to voices does not exist. Voice is not there. Hyperactive Wernicke area. The perception, when you do here, when I say to you, when I call you on phone, and just I say hello, just I say hello, yes, Dr. Adel, are you sleeping? I didn't tell you that I'm Adel. I didn't tell you that I'm sleeping. How did you discover this? From the tone of voice, not from your ears, from your brain. So your brain, you have brain center interpretation of the auditory area. This is very hyperactive and it fabricates voices for these patients. Evaluation of the home treatment for schizophrenic patients has a great advances. We can go to them and we can give them these injections and we can save their lives. MOH started a project 4 or 5 years back to reach homes, and they have around 50 to 100 patients every month. They go to them and they give them the monthly injections. 1 male nurse has been killed in Medina. And this is usual. Riyadh.
دكتور عادل 5 minutes more عشان discuss.
طيب ده لسه في فيلمين تانيين. Okay. The outcome in early onset schizophrenia revisited findings from early psychosis prevention, intervention, and center long-term follow-up studies showed also that there is advances if I did this kind of service. The emergency psychiatry, a neglected area of Cinderella services. They call it in UK and the Scandinavians Cinderella services. We don't know the story of Cinderella. When the prince married Cinderella, what did he do with her? I think he let her washing the dishes also. Yes. They call psychiatry Cinderella services. They will never care for psychiatry, and they will not refund psychiatry for out-home services. The effective long-acting injectable antipsychotics on hospitalization decreased very much the hospitalization rate, the global functioning of schizophrenia, naturalistic mirror and image study. The perfect doctors in China, this term is old, in 1975. They want to reach homes and to take care of psychiatric patients in their homes. What happened? They have to go to rural areas, no streets. How can they walk? No transportation. The doctor has to walk in rice fields. So those doctors has been trained to walk barefoot, يعني يبقوا الأطباء الحفاة. فالأطباء الحفاة كانوا بيمشوا بالشكل دوت، والترم ده نجح جدا في شاينا وعملوا جيل من الأطباء الحفاة اللي يوصل ليه المرضى. Okay, I will let you also share me this story, the judge in home. This is Fakeeh care also. Adi. This judge, the family came that he has a change of behavior. He is judge in the court for several years. He is 75 plus, and male judge, lately showed irrational behavioral changes. He is very highly provocative, easily moves to aggression, shouting, non-necessary, refusing to visit hospital, and routine lab was done by the nurse in home, showed mild, rather controlled diabetes. I remember this patient when I went there, I just were looking like this for the home. The watchman, الحارس, طلع لي وقال لي, are you coming for X? I said, yes. He said to me, he's Alzheimer's disease. الحارس. I told him, did you diagnose him? Yes. He gives me money and asks things he did not ask before. And then when he sees me, he asks me for things he did not ask me before. What is this except Alzheimer's disease? Oh my God. For how long he is doing this? For about 4 to 6 months. I don't know what to do with him. Sometimes he shouts to me irrationally for things I did not do. Then when I met the father, when I met the judge, the family were divided. Some of the sons, they deny the diagnosis. They don't want to know. Our father is sharp memory. He is very good. He understands everything. And others are declined. We, of course, also paid too much effort to convince them to go further for investigation, more investigations, and to stop working. He refused to stop working, and they refused to stop working. 1 year later, there was a tragedy in the court because he shouted at the lawyer 4 times in 1 minute, and he said to him, "You didn't tell me your name. You didn't tell me your name." So the consultant sitting said that, okay, okay, and they took him to the other room and asked the sons, check your father, he will not come to the court again. So, absolutely different experience when you see the patient in home and when you see the patient within the family. It is different than meeting the patient 15 to 20 minutes in the clinic. Absolutely different experience. You collect more information. You are near to him more than anything else. Okay. خلاص يا فندم. يا
خلاص وقفت الحاجة.
لا وقفت. اجيب لحضرتك كونكلوجن على طول؟ ايوه خلاص. هو في فيلم حلو انتوا حرين انا ماليش دعوه. Okay, these are the highest functions of the brain: orientation, attention, concentration, memory, thinking, abstraction, and judgment. This is the highest functions of the brain, so the Alzheimer patients or stroke patients, they have decline of this functioning. Those patients are deteriorating in hospital. This is very, very important for the nursing staff. Why? Simply, I will shorten it up. Unfamiliar faces, unfamiliar place, unfamiliar voices. So the memory will decline and the thinking will decline. So these cases must be treated in homes. Alzheimer's disease patient, post-stroke mode disorder, multi-infarcted dementia patients. Can we approach a locked-in addict, highest possible risk psychiatric mission? This is another case. He attacked me by a gun. We will skip it. Benefits of mental health support. It is convenient, does not require travel, driving, parking, easily scheduling appointment, broader reach, fewer barriers. And it has potential drawbacks. Access to technology services may be limited by lack of internet connection and devices, quality issues, cost, privacy, and insurance covering. To sum up and conclusion, psychiatric home care is certainly necessary for patients, families, and society. The quality of service and work requires knowledge, experience, and highly trained staff for proper, safe approach. The psychiatrist is almost always to be blamed. We have a doctor, my colleague, and she attacked by a knife inside the ward, and she had a cut wound in face. Insurance companies and charity organizations should evaluate the optimum value of saving patients among their homes and families. It carries cost reduction benefits on long term. Telepsychiatry can support the home care and facilitate services in e-lab and e-prescription. Thank you.
Thank you. Thank you, Dr. Adel, for very, very informative topics and important. Our speaker now is Dr. Maher bin Jadid. Dr. Maher is well-known national figure in Saudi Arabia for physical therapy and rehabilitation. Dr. Maher is a consultant and well-known director of functional healthcare in Prince Sultan Military Medical City. He's a chairman of Scientific Council of Saudi Board for Physical Medicine. He's the president of Saudi Society of Physical Medicine and Rehabilitation, and in fact, a very long CV. Dr. Maher will talk about tele-rehabilitation during COVID pandemic. Dr. Maher,
thank you very much, Chairman. Thank you, Dr. Salim. Many thanks to Fakeeh Group for inviting me, and many thanks for the scientific committee. Thanks to Dr. Mirvet, thanks to Dr. Wasim and other colleagues. Thank you for your attendance too. My talk is going to be summary about what you have heard. It's going to summarize most of what others have mentioned previously in the morning session. So I will concentrate on the tele-rehabilitation of COVID, during COVID in Saudi Arabia and the guidelines. I will start with the next, please. I can change from here. Nothing to disclose. Okay, the rapid development of modern technology has allowed the healthcare professionals to adapt these changes and deliver healthcare in a new remote techniques. And that really has helped many countries in doing it. Tele-rehabilitation is one option to expedite communication and counseling between the healthcare practitioner and patient at distant locality, and that has been mentioned also in the morning, mainly for a rural area, isolated communities and pandemic can benefit, and there is no more proof than what happens during COVID. And we'll talk about its benefit for, a large size country like Saudi Arabia, which is 2.2 square kilometer. Studies mainly during the pandemic have proven its effectiveness. As you know, since March or since February 2020, there has been many studies that has covered, a lot about the COVID, about its side effect, about its complication, and about its psychiatric and psychological impact, the social impact, and everything, including, of course, the rehabilitation for a person with disability. Just to go back to what has happened because of COVID or since the COVID, during COVID-19, most of the rehabilitation inpatient units worldwide was converted to acute unit. Like in our hospital, King Fahd Medical City, which used to be having 100-bed rehabilitation hospital, has become an acute COVID. Also, our unit in Prince Sultan Military Medical City were converted to an acute unit. But this doesn't mean that the rehabilitation physicians were left alone. We all went to manage patients in the COVID ward by rotation because the internal medicine and infectious disease and pulmonology were overwhelmed. So we were honored also to help the patients by looking after them during the pandemic. Some patients were discharged to long-term facilities, which has also outbreak in some countries, mainly in Italy. You know, they discharged patients from the acute hospital to a long-term facility, and there was an outbreak of pandemic. So they were not only left without rehabilitation, they ended up having a COVID with a lot of mortality. Other discharged home with lack of proper care leading complications of deconditioning and immobility. Of course, as mentioned before, the deconditioning complication will include pressure sore, infection, contractures, and others. Home health care, mostly of the public sector, were put on hold. In the government, in the government, Minister of Health, National Guard, military hospital, they were all put the home health care on hold. Mobile rehabilitation team, and what they call in Canada, for people who were trained in Canada, they know about something called rehabilitation in the home, or RITH. That was also discontinued during the COVID. This resulted in the need to adapt tele-rehabilitation due to restricted traditional in-person visit all over the world, as well as KSA. There was no tele-rehabilitation guidelines that are practiced, worldwide until 2019, when China announced about the pandemic starting there. And limited information about rehabilitation were available in Saudi Arabia. The specialized rehabilitation center and services are limited in number. In Saudi Arabia, there are very few inpatient rehabilitation facilities. Maybe in Riyadh there are 4, but I think in Jeddah here there is Abdul Latif Jamil Rehabilitation Center, but if you go to other city, you hardly find any inpatient rehabilitation facility. Rise of COVID-19 in the main cities of the country, the provision of care by reaching out the underserved region using telemedicine technology should be considered as a key to solve this problem. And that was really the changing direction of the telerehabilitation. The statistics as of December 2022, the number of COVID cases worldwide reached to almost 642 million, with 6.6 million in Saudi Arabia. The cases were around 825,000 with around 10,000 deaths, and the percentage or the mortality rate or the incidence was up to 1.1, 1.15. So it's it matches with the international number. Okay, the current situation of disability in Saudi Arabia, as you know, that the prevalence of disability in Saudi Arabia is up to 7.1, but worldwide it's estimated to be 15%. And in Saudi Arabia, most of the cases are mainly with the mobility impairment, although this figure I'm not sure about its accuracy, because I think the most common cause of disability worldwide is depression, and Dr. Adil can also elaborate on this. Okay, person with disability, especially early on during rehabilitation, are of more risk of COVID-19. This is because of some of them are deconditioned, some of them are immunocompromised, may need close contact with others who may be infected, such as direct support provider and family member. What I mean by this is, imagine that if there is somebody with tetraplegia following spinal cord injury, those patients during rehabilitation, they would need a lot of contact, turning by nurses. During therapy, they have to be with in-person contact, so you cannot really remotely treating them when they are in the hospital. Difficulties understanding information or practicing prevention measures such as hand washing and social distancing. This is because of maybe some of them have got some cognitive impairment. Others are really having maybe sensory, like some of them maybe could be blind, could be deaf, or they have some sensory disability. So they would have really difficulty communicating with people around them. People who may not be able to communicate symptoms of illness, like patients who are having dysphasia or inability to write. Okay, so we need to consider rehabilitation. The impact of COVID on rehabilitation services, it has really affected the rehabilitation services in up to 73%. And of course, the dental were the highest services that were affected. Although in some hospitals, including Prince Sultan Military Medical Hospital, we adopt mobile dental care that the patients who were in need, so they just call and the dentist with their team can go home and manage them. Okay, so in the study that we have done, it's just an observational and seeing what was written in the internet about the guideline. The objective of this study was to describe the perspective of telerehabilitation in Saudi Arabia during the COVID-19 pandemic. The goals was to increase the access for patients to therapy services. The method, there was, we collected data using the PubMed, Google, and Google Scholar with a specific keyword until the 6th of December 2022. No criteria for publication data were set, and all relevant articles published in the English language were retrieved and reviewed. The following keywords were used to find relevant article: telerehabilitation, rehabilitation guidelines, COVID-19, SARS-CoV-2, coronavirus pandemic, and Saudi Arabia. The result in the early, first of all, in 1960, that was after the outbreak of poliomyelitis in Saudi Arabia, modern medical rehabilitation started in Saudi Arabia, maybe in the major city, including Riyadh. Considering the current global pandemic and higher number of people with disabilities, which we said that globally up to 15%, in Saudi Arabia 7.1%, telerehabilitation may be a viable first line option for rehabilitating patients with disabilities in Saudi Arabia. Currently, several rehabilitation centers have started in Saudi Arabia. However, there is still a great need for more rehabilitation centers, mainly telerehabilitation services, because of chronic disease, the growing population, the increased rate of road traffic accident, and COVID. Although I think road traffic accident has been really reducing, the number of deaths in Saudi Arabia is really getting less. I think 10 years ago...
Dr. Maher, you have 5 minutes.
Okay. 10 years ago, the number of deaths in Saudi Arabia because of RTA reached up to 10,000 per year, and I think it's now reducing to 5,000 to 6,000, and hopefully, inshallah, we'll see a reduction more because of the road law enforcement. The results studies have shown that telerehabilitation is well received by patients as standalone treatment or when supplemented with conventional face-to-face therapy. Patients have had positive perception of telerehabilitation services, mainly due to a huge advantage, and we have some advantage here in Saudi Arabia. In Saudi Arabia, because we still practice an extended family, telerehabilitation could be conducted even without having a professional going to home, by really advising the patient about what to do. For prevention like of contracture, by doing passive range of motion daily, by making sure that the patient are turned every 2 hours, by seeing how the patient are fed and whether they are really fed while they are in semi-supine position or whatever. So they could be really helped by prevention some of the complications associated with bedridden. Telerehabilitation increased the flexibility of session time and reduced the need of patients need to travel and attend clinic in person. We adopted a guidelines that was published in line. I'm very much proud to be one of the team who published this paper, and we found that in Saudi Arabia, telerehabilitation guidelines developed recently to support provision of rehabilitation facilities distantly by collaborating with healthcare provider in different regions of the country using recent information and communication. These guidelines present general principle connected with telerehabilitation in Saudi Arabia. Above is not anticipated to replace clinical practice guidelines in individual judgment, which could be understood. Such guidelines provide a system of delivering multidisciplinary rehabilitation care in distant location and expand accessibility and standardization. So when we talk also about telerehabilitation, we're not only talking about what physician can do, but of course, most importantly, the nursing, the physical therapist, the occupational therapist, the speech and language pathologist, and the social worker, and the psychologist, and others we never needed. So we have developed practice guidelines, which is divided into administrative guidelines, clinical guidelines, and technical guidelines. Telerehabilitation guidelines were developed to assist providing rehabilitation services remotely, and this is just, of course, among the physicians are physical medicine and rehabilitation, the team. In conclusion, the telerehabilitation is an outstanding choice that should be implemented in all rehabilitation centers in Saudi Arabia as early as possible to face emergencies such as what happened during the pandemic. Also, to fill the gap to improve medical rehabilitation in rural area. As we said, the number of inpatient rehabilitation facilities in Saudi Arabia does not exceed more than 10, and the gap between the available and the need is quite huge. We recommend that rehabilitation professionals, in concurrence with professional authorities, encouraged to use the Saudi guidelines for tele-rehabilitation as a resource for developing discipline-specific standards, guidelines, and practice guidelines. Thank you very much.
Okay. Thank you, Dr. Maher, for this comprehensive presentation, and we learn some about tele-rehabilitation, which I think we had very good experience in Saudi Arabia. We are proud of this one. So now we will give question. We'll try to take 3, maximum 4, short, concise question for Dr. Maher, Dr. Adil, and Dr. Hana. Dr. Hana. Mic,
Thank you very much, respected speaker. It really was presentation. My first question to Dr. Adil about home health care for addicted personnel. They have a very nice Fakeeh care. They have a very nice conference last Sunday about addiction, and I need from Dr. Adil to give us the conclusion, the outcome of the conference, and what the things we need to do or we have to do to our addicted people.
I speak only about the home care approach. The home care approach. The home care approach is quite different from the patient coming to you. The patient coming to you, usually in Fakeeh Hospital, we see the patient coming for detoxification. He is using, and he is intoxicated, and he is started to be have a picture similar to schizophrenia or schizoaffective disorder, drug induced. But for the approach, the case I did not show, the mother came to me several times telling me that my son, businessman, father, he has 4 children, and he is daily user for the last 6 months. After some years he has it. And how can I go for them? He is old, responsible, and well-known figure. How can I go to them, and what is the approach? She said to me, he carries a gun, he is very aggressive with every one of us, he is taking chabu. Okay, call the police. The police refuses to help. What can we do? I refused. She came again and again. Then she said to me, he is okay now, and he is accepting you, and he is waiting for you. And it was a trap. And when I went there, she moved me inside, and she said to me, this room. I told her, okay, go inside and open the door and tell him the doctor is here. She said, okay, come with me. She pushed me in, and she locked the door. To my surprise, I found man fully naked, burning coke and burning heroin, and cooking all kinds of narcotics. He has knives and he has gun in front of him. He carried his gun. Who are you? I'm going to shoot you. I said, okay, your mother is dying. I'm a doctor. I'm just a doctor. I will lie to her, and I will tell her that you are okay. I will lie to her. I will tell you, I will just leave me 1 minute, and I will go out. I will tell her that you are okay and everything. And then to my surprise, we started the interview, and we started calming down, and we stayed maybe for about 2 hours. He tried to invite me for some coke or something. I said to him, please postpone this till I leave, because you might die at any second from this. And to my surprise, he accepted for detox, he accepted for everything. Just we can approach one step. And sometimes he has a weak moment. We can reach this moment. And an access person, maybe the doctor, the brother, the father, the mother, we will never be desperate just to talk to him at different times till he has a submitting point, a submitting moment. Okay, I'm ready to be treated. If we reach this view, this man is much better now, and he's one of my best friends. Alhamdulillah.
Yeah, very exciting experience. In fact, during our experience, I have 6 or 7 addicts, and they are when you go to their homes, because they thought that when they come to the hospital, it's really a sort of stigma. social stigma. But the first question they asked me, I directly managed to with the psychiatrist. He said, nobody knows. I said, nobody knows. Confidential. And then they decide to respond to the medication. Very good. Type. Any other question?
Yes. For Dr. Adel also, we in home care have a high incidence of depression associated with our special elderly patient who has recently stroke or any disabilities. And this depression sometimes affecting their will to receive help or medication. One of my patients refused even to go for hemodialysis regularly. Even we offer for him home hemodialysis. He refused for help for. Even we offered him to send psychiatrist. He preferred to die.
Food refusal, drug refusal, doctor refusal is a sign of depression. After stroke, we have what we do call post-stroke depression and post-stroke psychosis. And there is research according to the type of stroke and the place of stroke. The more frontal, the more deep goes with depression. The more frontal left hemisphere and go deep, it is psychosis, schizophrenic psychosis. They have poor orientation, poor attention span, poor concentration, so they respond by rejection. Sometimes also they are partially dysphasic. He does not understand the full sentence you say. So he rejects what is said, which I cannot comprehend, I cannot compensate. So reorientation therapy can help very much. Reorientation, and I teach the family members how to reorient your father, to reorient your grandmom, your grandfather, and how to reassure them for this. This is the first approach, and then of course medication. Dr. Maher wants.
Thank you, Doctor. And if I may comment, I'm very much honored by looking after many stroke patients since I practice physical medicine and rehab. Like we always, when we talk about depression in a stroke patient, we divide it into two, extrinsic, which could be also part of the neurosis, because it's a reactive to somebody losing their ability to walk, their ability to be independent in activities of daily living. So it's an extrinsic. Once the patient improves, they will start to be reduced. And the other one is the intrinsic due to the neurotransmission in the brain. And as we know that, as Dr. Adel said, the more it is to the frontal lobe, the more the planning and the personality changes. And it's always mentioned that even the depression is really could be very much not seen in patients who have got very good supportive family. So the more supportive family that people will have around them, looking after them, not only overprotection, but giving them the required care. And sometimes it makes even a big difference for patient. Like if the patient used to shave every day and then he had a stroke and he hasn't been shaved, every time he look into his face he said, I'm neglected. So there are really some people who are really sensitive in that. They will try to dress the same dresses. If they get used, even getting them, because they have got hemiplegia, they will get them only hospital gown that they will be dressing them with all the time. They will feel that they are patient, they are not loved anymore. But I found that they will look happier and smile in front of you if the family are really trying even to dress them with the same thing. Try it, of course, depending, of course, on their medical condition, that they will get him. They will look exactly the same like before, because the self-image would make really a big difference.
From the survey we do for home health care, we found out in general 65% of our geriatric home health care have major depression. Post-stroke, 79% of post-stroke, especially bedridden, they have major depression. You are right, because he was active one day and he was going to his office or work and independent, and then he will be bedridden and dependent. Yes.
So can we put in our program in home health care psychological evaluation?
Of course, yes. Yes,
this is
very good. We have some teams, they have clinical psychologists. yeah, within the team.
No.
Yes, thank you. Yes, please.
Dr. Adil, can we create or do we have a simple tool for screening for home care physician and nurses to catch the patient with psychiatric illness or addict patient? Is it possible?
هياخدوا شغلك يا دكتور.
Just so we refer the patient to him after that.
It has.
But because we are seeing the patient more, nursing and physician, home care physician.
Sure, yeah, yes, of course, of course. And we can at least we can make a group meeting and we discuss what issues we can see and we can transfer and convey our experiences together. Yeah, sure, sure. And we can have a protocol and logistics how to approach.
I think this is give us idea that we maybe in the future we have a session or a symposium about psychiatric problem in home health care. I think need more. I would like in the end to thank our three speakers. Dr. Adil, Dr. Maher, Dr. Hana. Thank you, audience, for this session. Assalamu alaikum.
Thank you, Dr. Salim. Thank you, Chairperson. Thank you, everybody. Dr. Amarvat. To close our session in the tele-rehabilitation regarding current, future perils and challenges as well as how to overcome it, we would like to first call Dr. Maher Al-Jadid for his speech on tele-rehabilitation during the COVID. تفضل دكتور ماهر. For her lecture in New Era of Nursing in the Home Health Care, Dr. Hana Al-Uthaymi. On the session of telepsychiatry, promise, potential, and challenges, we would like to honor Dr. Adil Siraj for his presentation, Quality of Life Psychiatry Illness in Home Health Care. Thank you all. Now we will go for our last session today in excellence in home health care. In this session we would be discussing our either trending in new trends word in home health care process, operation and flow. We would like first to start by the lecture of Dr. Ahmed Tulba, New Trends in Wounds Management in Home Health Care.
يسعدك طمنا عليك بس. Okay. I'm presenting our home healthcare family friend, actually, Dr. Ahmed Talba. He's really supportive and he's always responding to us for such referral cases or even يعني for any simple consultation. So many thanks for this. Dr. Ahmed Talba, he is our Fakeeh wound care physician and orthopedic resident. He is also international interprofessional wound care. He took it already, the course from Toronto of Canada. Please, let's welcome Dr. Ahmed Talba to discuss the new trends in wound management.
Hi everybody, how are you? Can you hear me? No need? Okay.
This is low volume.
Huh?
Low volume.
عايز امسك حاجة تانية. Sorry. For our presentation today, oh, it isn't working. Okay. We will talk first what we are doing in home health care and what we are doing in the hospital as total. This is the like new position or new activity we are doing at hospital that for the wound care started since about 2 years now in the hospital. And we have a team now working for this one, and really I was surprised with the efficacy of our nurses in home health care for follow-up of the cases and the challenge with it with a lot of patients during this last only 1 year. Okay. Our objective here in this presentation, we'll talk first about the progress in the patient wound care and home health care, dealing with limb salvage, continuous care with the close follow-up, patient and family satisfaction, and the meaning and purpose of wound bed preparation. That's the main target we are doing here in wound care. And participation discussion later on, and share ideas around how to improve our outcome later. The outcome will be wound care importance and how we deal with the patient as package for comorbidity and everything, and then recognition of the challenges and the wounds and how to define these wounds and how to deal with. Then differentiation between all. Decision taking and decision making. This is only one man show. It's all, we are all together to get the good improvement for the patient. And later, the teamwork. And first, we have this, the largest organ of the body is the skin. The skin contains the epidermis, dermis, hypodermis, and what's contained as the main targeting for the skin, or the main function is protection of our body. For the wound classification, first, we are classify the wound according to the thickness, complexity, age, wound origin, and these subtypes for this one. Then how we are doing with the wound healing, and how we are doing with the wounds, how to push this wound to be healed. All this one during our discussion or our talking about the wound bed preparation. The wound healing is going through primary or secondary or delayed primary healing. This is according to the type of healing of the wound. And then the wound bed preparation. This is the scheme for the wound bed preparation. We are using this for the person, just first for all, define the person with chronic wound and identify, create the cause, and share the family, all of this. Then this wound classification is he has ability to heal or non-healing. How can we deal with this wound to get the good benefits? Then we push to the next step is the local wound care through what we call DIME, debridement, inflammation, moisture, and then the edge, dealing with the edges. We will go fast through this wound bed preparation. the systemic approach to wound management by identifying and removing the healing barriers, the concept of preparing the wound bed to promote rehabilitation or revitalization, for chronic wounds has been applied to wound management. The 4 general steps is DIME. DIME is debridement, I for dealing with the inflammation and the infection, M for the moisture balance, and E for the dealing with the itch. For the debridement, the essential element of effective wound care is the debridement. Meaning of debridement is removal of the barriers from the wounds. How to remove the primer, how to remove these barriers so we can fast the healing of the wound. Barriers include any infection, the slough, dead tissue, anything like this. The debridement has a lot of things we can use: surgical, enzymatic, biological. For our care, for our home health care or our care of the patient, most of cases we are using the autolytic debridement or enzymatic. Now we are using enzymatic debridement. Some cases need surgical debridement and the intervention with the physician, maybe in the hospital or on the bed, on visit. We are doing this one. Now we will push to the second step as fast. Inflammation and infection, how to deal with the inflammation and infection by systemic antibiotic or local antibiotic or something like this. According to classification we are using, this is Stones and Nerds classification. Nerds classification, 3 or more for present to deal topically. This non-healing wounds, exudative, red, depressed, smell. Or for the Stones, for to treat it systemic, through systemic antibiotic, that the size getting better, temperature, this is exposed bones, new breakdown for the tissues, or exudate increasing, so we can push to systemic antibiotic. Cleansing, this first step we are doing with the nurses or doctors in any place, in the hospital, in home health care, removal of the foreign body, removal of the slough and the necrosis by using some washing. And then biofilm management, that's we are dealing with the infection through antibiotics, otherwise local or systemic antibiotic. And moisture balance. This is the main issue for wound healing. This is the moisture balance. How to control the moisture of the wound. The wound, if highly moist or highly dry, will not heal. So moisture balance is crucial for us to deal with. No, we want the wound to be balanced. The moisture, if increasing moisture, then increase the infection and the wound will be delayed healing. If dry, the same. Then the wound edge and how to deal with H1. Edge management, this is the common side we see. This is the enrolled edges of the wound. And also if the hyperkeratosis, especially in diabetic foot, so shaving and everything. Undermining and tunneling, these some issues for the also we are seeing in the wound, especially in the pressure injury. And last of it is monitoring. And this is the main issue we are doing with the patient. We must monitor the healing of the wound to see our progress. If it is progress, or we can stop with the dealing with the wound as wound, healable wound, to push it to maintenance or non-healed wound, so just to keep it out of infection. And this is the wound dressing. Most of them we are using. A slide later. This is our team in the hospital for the wound care team. This is started since about 3 years by our professional nurse Janet. Now she is in Canada, and now we have Genevieve. And this team is responsible for the dealing with the wounds inside the hospital for classification and management. Now, for short, I will see some cases we deal with this patient in the home health care. First case is combination, dealing with the patient inside the hospital and the home health care. This is 65 years old patient, diabetic female, presented to pediatric clinic on March 22 with left foot necrotizing fasciitis due to diabetic ulcer since 2 weeks, with offensive smell and pus discharge. By first look, doctor can think such patient with necrotizing fasciitis, we are pushing the patient for below knee amputation. But we have other decision. Decision changed to give a chance, planned for urgent debridement, fasciotomy, sequestrectomy, and antibiotic, local and vac application. Patient admitted to the hospital, underwent the surgery, and then discharged to home. This is the first dressing post-operative before discharge. The patient underwent OR, and then this is the small things is the antibiotics we are giving. Antibiotics is bone graft with vancomycin and gentamicin, and we apply vac. We make excessive debridement for all dead tissue or necrotic tissue. Then follow-up. The patient discharged from the hospital at home health care for regular dressing with close follow-up. Then reassessment done, starting with granulation tissue formation, but still have necrotic tissue. This is what we see now. It is forming new granulation tissue inside, but outside there is some still necrotic tissue. We get the patient admitted again after 1 month on April 22 and had other session for OR debridement and vac application. Then after 6 weeks of continuous and regular home health care follow-up via debridement and vac dressing and other ointment, we are using some autolytic debridement with so what we have alginate, and prognosis was surprising with very nice granulation tissue. We have this granulation tissue within 2 months. Then the patient planned now with the good granulation tissue for skin grafting. Patient admitted to the hospital again on June 22 and underwent OR for skin graft and the full coverage of the ulcer. Then patient discharged to home with home health care on vac dressing and regular follow-up. This patient follow-up done and staples removed. Then patient referred to special orthotics. Now she has her foot, and now she is wearing the orthotic and is walking on her foot. So we save her leg from amputation by this debridement and the close follow-up from the home health care, our home health care team. Where this is what we call this cooperation between the two teams. Now we save this patient life or saved her limb. Other case is purely treated at home with pressure injury, heel ulcer, diabetic heel ulcer, 8 years old patient bedridden with heel black eschar. In first it is stable and we are dressing only with betadine. Now and later on it is changed to be unstable and having pus down. Local debridement and the removal of the ulcer done, and now we have a lot of stuff how to deal with. We started with him local debridement, and to start with him, we started with him management with collagenase and hyaluronic acid, what we call enzymatic debridement. All of this at home. We didn't admit the patient to the OR or admit to the hospital. Just we are dealing at home. This after 5 weeks. Now we started to have granulation tissue. After 8 weeks from using this one, it is closed already. And I shaved this one, but I don't have the last picture. I shaved this one. This is heart tissue or callus. We shaved this one, and he is improving. We have a lot of cases. This is our case, Dr. Rashad. Okay, this is patient with. The first picture is not the first case. It's not the first picture for the patient. I saw the patient in the hospital. He has severe infection, stage 4 pressure injury, with offensive odor, a lot of pus, a lot of necrotic tissue, and really I pushed him to do it surgical with the plastic team. But the plastic team, they said we can do anything for this patient, just we will wash him. So refer back to wound care. On wound care, we started with him debridement, we started with him local debridement and the application of the vac. Then the patient referred to home health care to be discharged on the vac dressing. Really, we have amazing development, amazing healing for the wound. The wound is closed. I was surprised. Really, I saw the patient the first, and then we pushed for that, and he is on follow-up with the home health care team. Pure. I just saw him. After, I think, 3 to 4 months later, I saw very good granulation tissue. I was surprised for this one. We stopped the vac, and we started with him local ointment for healing, and now we close this case. Most of these cases like this infection, we can do anything, really. Just we keep him as non-healable wound. We classification as non-healable wound or maintenance wound. Just we keep him out of infection. But really with that follow-up with the team, now we have healable wound, the patient healed already.
Before we start, he had multiple readmission.
Multiple readmission because of the wound. Yes, from sepsis of the wound. Just when we started our treatment, خلاص, he didn't admit anymore for the sepsis. Never. And even he has a lot of comorbidity, and on regular follow-up at home, he has his own medication and he didn't admit again. I saw him, I think, for the last year, before we started our plan from management, he was admitted at least monthly. I saw him monthly in the hospital for staying for 1 week or 10 days, just receiving antibiotic, and then discharge on antibiotic at home and regular dressing. When we start aggressive plan from wound care and with the team of the home health care, a patient for the last 4 or 6 months, he just admitted maybe 1 or 2 times for the medicine, something of electrolyte disturbance, something like this, not for the wound. And later, the patient discharged, and when we regular follow up with the home health care, خلاص, now the wound is closed. Patient has no more sepsemia. Patient is happy, family is happy. And the problem of this patient is not only bedridden, patient is awake. Yani most of the patient of the pressure injury, we have sacral pressure injury, maybe in coma or something like this. But this patient is awake and he's oriented and he's willing to know what is doing with him.
Uh, 5 minutes more, Dr. Ahmed.
Okay. And we end with this one. One more case with heel ulcer like this. This was also treated at home. We didn't do anything, just enzymatic debridement for this patient, even no surgical debridement. Within 3 months, this closed like this. Also, this patient pure home. Patient didn't admit to the hospital. We have in the home health care, really, we have a lot of support and instrumentation we are using. We want to progress more, but we have what we want and what we are dealing with the patient. We are dealing with the patient at the hospital, at the home, like at the hospital for the care. Wound care program, this fetch that we have now, this wound care program started since 3 years. Yearly, we have graduated just since 1 week. We have the last graduation for 2022. This is training for the nurses for wound care, how to diagnose and how to apply the dressing and how to apply vac dressing and everything. Thank you.
Thank you so much, Dr. Ahmed Al-Basti. Don't go away because still we need you in the back. Thank you so much, Dr. Ahmed Tulba. It was really valuable and excited topic. As long as we know that most of the services that we are provided in our home health care related of the wound and the wound dressing. Kindly please, if you have any questions, so the mic will be with you. Any questions?
We can push the back and then we can make a question.
No questions at all? You have? Good. Please give him a round, please.
Thank you. We are in physiotherapy team in home health care. We can use some electrotherapy. Like ultrasound and laser, and this is very effective for wound care. And there's some research supported this healing, and maybe we can use this electrotherapy with some patient in wound care. Thank you.
Thank you. This is very nice topic. I just saw a lot of research, new research regarding this one, using the electric and ultrasound for the wound care, and this is will push for formation of granulation tissue. We can apply this one, but we must do some research on this one. The problem, it is not approved yet. All of this are case reports. But really, it is very impressive thing. I saw the results and saw some papers for this one. It's very, very good. Thank you.
Thank you so much. Anyone?
Okay. Thank you, Dr. Tolba, for your comprehensive speech. I would like to welcome the PAC team for our first discussion panel. In this session, as you all know, we are talking about excellence in home health care. One of our excellence in home health care is PACT program, which stands for Post-Acute Care Transition. This program is about patients whom just has been through a process of acute care at the hospital, either inpatient or as an OPD, but usually are inpatient patients. So those patients where we deal and treat with them at home to eliminate the aspect of readmission, the time of duration, and today we will discuss through this panel what are the objectives, what are the challenges and the obstacles, and how we are overcome it in Fakeeh home health care. Please, the panel, can you please have a seat? So, first of all, this panel was, this project first started last year at the last quarter of 2021, where we got approached by insurance provider approaching one of the problems that we face in home health care. This problem was a multiple readmission, a high consumption of the insurance limit for the patients at the hospital. Either those patients has multiple comorbidities, those patients has multiple readmission, either necessarily or not necessarily admission at the hospital. So with collaboration with our co-partner in the insurance, Buba team, we have tailored the program using the, excuse me, can you just please, okay. So we have tailored the program where we tackle some of the patients. Those patients has been through a multiple readmission, multiple frequent readmission. So the objectives first was to tackle and categorize those patients using the academic American Academy of Family Medicine categorization and stratification score system. And we maintain those scoring system in order to choose those patients and select it. Then we modify it by the process. As an outcome of this flow, and as an outcome of this program, we have been studying a sample of 100 patients. In the first quarter of 2021, those patients, the 100 patients we choose as a sample, their readmission rate was 21 monthly readmission. 21 monthly readmission. At the same period, in the same quarter of 2022, when we started the program, the admission was 3 patients in full quarter, which is, you are talking about the same sample, you are talking about more than 80% reduction in the readmission rate. And as per the data we received from the insurance company and the insurance partner we have, there were a 30 million reduction in the readmission cost of those patient limits, which is a huge number. So if we get this program has been started in the Western region only, so if we are talking about a bigger scale on the kingdom, you're talking about huge money saving, huge saving of the deductible amount on the patient limits. The process usually starts by selecting the patients, categorizing inclusive the patient during the inclusive criteria. Then we got referred the patient to our home health care team, and the home health care started by our case management. Here we will leave the floor to Mr. Mahmoud as a case management point of view, how we receive the process. As you all already know, the process of receiving the admission in home health care, and what kind of obstacles we faced and what kind of challenges we faced.
Thank you so Okay, I will just focus on the pact as what Dr. Wasim said. I believe that most of the audience here, they know the concept of the case management and how we are managing the case. And particularly regarding the pact, we starting first to review the case, to assess the first of the eligibility, and we need to know, and we need also to get the matching for those cases with our goal. So to address the case for the physician. So starting first to approach the patient, review the case, as what I said, to check the eligibility through the assessment forms and the assessment module, that matching with our policy and procedures in our Fakeeh home healthcare, I mean. And that's it. So after that, we are referring this case to the physician. But I need just to focus, because we mentioned, Dr. Wasim, he mentioned also the barriers or the obstacles that we are facing and how we are tackling those barriers. First of all, we have, I think it's common barriers. List of the services, if we are talking about if it's already we have those services or if we don't have. So we are trying to match the services that we are providing to the patients. Also, we are facing some of barriers like convincing the patient about the visit time, if it's suitable for them, as long as suitable for our line.
And if I may interrupt for this, Mr. Mahmoud,
yes.
One of the most important and the highest challenge that we faced regarding that challenge, one of our patients we called and we said that we need to do a visit to initially assess your status post discharge. He said, no, I'm good. Why I don't need this, I don't need that, and so on. We have been, we invested a lot of time to convince him. After 3 days, he got readmitted again because he refused to get this visit done and he refused to just discuss this with us. At the same time, the patient whom, as I told you earlier, the patient whom just compliant with our plan, their readmission rate dramatically decreased. So this is a very valid point, because some patients, especially in this region, I think that we have this kind of threshold of tolerating pain, and even sometimes we are ashamed to say that we are hurted or we are in pain or so. And that's sometimes we have this concept of I don't need to go to the hospital unless I'm dying. So yeah, that's true. So that's why one of the most important challenges I think the team faced, that just to convince the patients. After that, I think things goes on with the track, like as soon as the patient is convinced to be visited. From I think the physician point of view, still you have the same problem, right? Yeah, like can you just tell us about how you faced, like especially the resistance point of view?
The resistance only. Some patients prefer to keep in touch only with their primary physician. I don't need any interruption. I don't need any other opinion. So we offer, even I discussed before with doctor about the patient with depression. He is on hemodialysis. He has a pressure ulcer. He has regularly permanent Foley's catheter. He has many services, and we offer him to improve his quality of life. You missed a lot of hemodialysis at hospital. We offered you to come to your home.
Okay, how do you think, Dr. Rashad, we overcome this? Like, what was from your experience during this last year in this program? How we overcome it? How we convince or like overcome this?
Primarily to make our message is simple and clear. This project is to improve your quality of life, to help you. We will not deprive you from your right to go to your primary physician at any time or your hospital at any time. We only to fill the gap between your admission and the needed readmission. We try to fill the gaps and fix the causes and fix the problems with you.
Okay. What kind of gaps you faced more than the, like, if I would say the most important gap from your point of view as a physician you faced during this program and how you overcome it, what else you would mention?
Gaps like some patients, when discharge planners, sometimes they give them machines like oxygen concentrator or CPAP, BiPAP, any machine, and he not educated well about this machine. And sometimes he educated, but less concentration with the educator. We visited him and we noticed that he cannot use, or he knew but he didn't use. And sometimes we visited patients, he's diabetes, but or ischemic heart or heart failure, and he discharged without, he don't have glucometer at home, he don't have blood pressure machine at home to follow up his condition. So we need to make full throughout history and throughout, to make a tailored plan of care for him, all his needs.
Can you mention us like a success story happened, like especially in this point, because I think it's very valid, and any home healthcare practitioner might face the same thing, like just I don't want to leave my primary nurse, because even the concept I think is stuck in the mind even in the inpatient area. Some of the patients where they are admitted in some wards and there is a specific nurse for him, every day she comes for the last 3 days, so he don't want any other nurse to treat him. Same status happens with the physician as well. So how do you think like we can?
We have a lot of success stories.
Yeah, like just tell us one, please.
Okay.
So we are short of time. So
I remember one patient. I will not forget him at all, because my first touch with this patient, he has recommendation written in his document that he is recommended for heart transplantation.
Oh.
His ejection fraction is below 20, and he's very depressed. But after we started with him, filling the gaps, giving him orientation about what's the risk and what's the alarming signs, and highlighting his main problems, especially some patients have multiple comorbidities. He's now mobile. He didn't readmit since 1 year.
Wow.
Once.
Great.
And he's mobile. Every day he walking, and I will not forget this patient.
Interesting. As we all know, nursing is the cornerstone of home health care. So thank you, Mr. Nurse. So Miss Melissa, as a senior home health care nurse, one of our senior home health care nurses, what would you add, like from your point of view, as a resistance or as a challenge you have faced? It's not something new to the practice of nursing, but as we mentioned, or like one of the main co-factor in this program was the resistance of the patient. So what would you add for this from nursing point of view?
Good afternoon. I just want to recognize our very own nurses from our Fakeeh Home Care, most especially by our head nurse, Ms. Shaima, and our very own nurses who really give their time to come and attend this conference and supportive to us all. For our obstacles and challenges with regards to providing the nursing service to our patients, most of the concerns that they are telling us are the time management, like the visiting time. So we offer a lot of choices to the patients. This is a hot topic
in home care.
Yeah, it's as always the topic of not only for home care.
Yeah.
Even if I'm the patient, I don't want to have a delayed service. So we manage. We try to manage this by adding more doctors, adding more nurses to our home care facility, as led by our director, Dr. Mirbat. She was able to add more drivers, and our nurses now are also, they are better. They are giving the best quality of nursing care that our patients are receiving, and a lot of success stories have been shared, and they are very grateful with our service, like for the patients having wound, and most of them are being treated at home, and a lot of them, a lot of their wounds are healed by our nurses.
Yeah.
The hands of our own nurses, and we are very happy with this result. And other thing that I would want to share is their clinical concerns, like they might prefer other physicians rather than our GPs.
Sure.
But we offer them the teleconsultations, like referring them to our specialist doctors, and they are very pleased with this service. They are happy that they don't need to go to the hospital, they don't need to travel. They just wait at home, and our doctors will come to see them and assess them and provide the service that they need.
So we might say that even if the resistance is not breakable, we can just like deviate and take a bypass. So bypass the patient mindset. For example, some of the patients, especially in home health care, a lot of patients are geriatric patients and very are like they with a mental illness and such a scenario. So bypassing it sometimes is the best solution, like offering them, okay, if you don't want to be managed and seen by home health care physician, we can just like offer you a teleconsultation from your primary physician or your primary specialist or whatever, and we can even just ask. And this is the value of having like a big hospital as a backup for you as a home health care reference for, that's true. Whatever specialty you want, there is always. And that's like bringing me to my question to Dr. Tolba. Dr. Tolba, in spite of his role as a home health care team, he's always support of us actually. Though he's not based in home health care, but always he's visiting with us, whatever regards like wound management and so on. But I'm gonna ask him today regarding this post-acute care transition program. What do you think that the specialist role flow should be, and what kind of obstacle do you think that the specialist might have, whatever the specialty is?
First of all, I want to thank you, and it's my honor to be part of this institution, home health care, really. I have a lot of success still with the team in the home health care, and I appreciate their work very nice. For a point of view of a specialist or specialist referral, all this, this is, as you told, that we have the home health care have the backup like Fakeeh Hospital with all the specialty as tertiary referral. It is very nice that you have this backbone that you can work on in this one. The specialists, most of them, the main obstacle of this one, instrumentation. Most of the patients, they are dealing with us at the hospital during admission or in OBD, but in the home health care or in the home, when we are visiting him at home, you don't have an instrument otherwise for diagnosis, for investigation, and for treatment. If you have these issues, really, all of us will have success. For my point of view, as surgery or orthopedic or as wound care for our patient, we have these issues. I think it is improving one day by day, and with the administration cooperation with us and the nurse help and everything, and all the team, the doctor, physician, the first of management of the case, we have here the physician seeing the patient, and they confide the problem and the infection regarding my subspecialty, and this, the wound and how to deal with this. And the nurses, they are following, and then we are putting the plan, helping the patient to go to improvement using the instrumentation. Really, when I'm starting to work, first of all, we don't have all the instrumentation. I have my own. Then, halas, later on, I am bending all with the instrumentation of our team.
You can ask.
For me, this is the main issue for the specialty. We are coming the instrumentation using for diagnosis and everything. Even for diagnosis, we are using this is our radiology and the lab investigation. Really is improving day by day. And we have one patient. This is a young patient, CB. We diagnose at home. She has pressure injury stage 3. Then with negligence became stage 4 with infection. We just order for her culture, local culture, done by the nurse on the next visit, and we have infection. We treated the infection with antibiotic, and patient on VAC, and now is improving and getting granulation tissue. Family is happy. Patient didn't admit it anymore to the hospital. Since starting the infection till now, no admission. Patient is improving, and there is no more fever. And we now planning later on. I will check her maybe in this week, just to check if she is available, if you can go progression for the local debridement or local management at home, or send for plastic surgery to cover this one.
I want to highlight something. Me and my colleagues, Dr. Atumadur, Dr. Farid, and Dr. Ahmed, Dr. Yasmin, in home care, we found much cooperation from our specialty, from our hospital, Dr. Ahmed, Dr. Muhammad Safwad, and all other doctors. They have much cooperation with us. One important thing about this BACT program, not only the patients post-discharge. Some patients, we visited them as chronic patient, regularly assessment. We found that they are eligible for this project, and we refer for getting approval to join this patient to the same project, and we get approval, so we put the patient on the program. One important thing when we are making assessment for the patient in the first visit, assessment visit, I said we need to fill the gaps. Some of these gaps we need to be tricky. That sometimes the discharge summary miss a lot of problems.
Yeah, this is the main issue.
Yes. Patient may be lost admission during because of electrolyte imbalance, because of heart failure sign and symptom, and we visited like this. But we found the patient has pressure ulcer. We found the patient is chronic kidney disease or hemodialysis or any other problems rather than his main problem during admission. So our plan should be collaborative, should be tailored for the patient, all his needs.
And actually that's what makes it a very specific and concise project, because it's very tackling for each issue with a holistic approach at the same time. And rather than usually, with all the respect for the specialty, usually if the patient is admitted in the ER, we will manage whatever that there is emergency in his situation. He is stable, khalas, discharge, and that's it. Or he should go to the ward. And even in the ward, they would manage whatever he got.
I didn't
admitted.
ask my question yet.
Yeah, he will be managed only for the issue or the clinical condition that he has, not all the story of the patient. That's what makes the project actually very touchy for the patient. You can proceed, Dr.
Yes. For Dr. Tolba, currently our practice now, we after as a home care physician visiting the patient, making the plan, making the assessment plan, filling the gaps. Our plan contain refer or need consultation wound care specialty or whatever the patient need. Do you feel that follow up the patient wound by image is enough, and how frequent you need to see the patient?
It all depends about the condition of the wound. Some wounds no need for regular follow-up, and some wounds for me I insisted to see the patient within 2 or 3 weeks on follow-up or regular follow-up according to the type of the wound, according to the patient at all. But really our physician they are in the home health care, they are taking care for this one. Not important to see the patient because you are the one judging, you are the one diagnosed first and referred. Then we will put the plan, anti-clear plan. We are following together, and during your reassessment, you just put the patient. You are seeing that the patient no, they must be referred again or continue on the same management. And the picture, from my point of view, some patient, this picture is enough for me, but some patient no, we need especially when we talk about the inflammation and infection procedure, stones and nerds, and how to start local and systemic antibiotic and everything like this. during the dime or what we're using for wound bed preparation. These basic issues. I think some patient like severe or stage 4 pressure injury or diabetic foot needing regular follow-up in OPD or at home. As the plan, we are putting this one, but most of our cases it's improving. Picture sometimes enough.
Here I would like to, Mahmoud, you have something you want to add?
No. I need just to thank you for this project, and this is the idea. You know, this is the hot topic of how we are just. It's not a classic lectures or it's not a classic presentation. It's just a hot topic that we are discussing and that we are trying to convince each other. Thank you so much, Dr.
You're welcome. Thanks to you.
Again, we will go back.
Last comment for one thing important or difficulty or challenge in our program, that the patient may be admitted in different facilities, not only in our hospital. So we need some part who coordinate to getting us for continuity of care to get this.
Sure.
This one challenge we faces, that the patient may admit or readmit. There is time, or
we have 3 minutes for question actually. If there is any question from the audience,
we can get question from the audience.
Thank you so much,
Doctor.
Yes.
Very impressive experience and to hear about it. And I just wrote in the recommendation. This experience really should be, put on and supposed to go to مجلس الضمان الصحي اللي هو which is responsible for the insurance companies. I'm sure insurance company will be very happy to reduce the cost, or what we call it in health economic cost reduction approach for healthcare. And at the same time, of course, when talk to health, no compromise. That's why they say cost effectiveness. The cost and the health also. Health is more than, of course, the cost. And the home health care, one of the strategies, those who work with us since 2004, when we started with the Saudi National Home Health Care, المؤسسة الخيرية الرعاية المنزلية. We do 3 international symposium, and this symposium I think we convince Ministry of Health to start home care through one of them is cost reduction, or anyway I think this one should be really should be written, putting all the policies and all the procedure in it, and should be shared with other health sectors and with مجلس الضمان الصحي. وشكرا على هذا.
Any other question? All is good. So thank you all. I really appreciate your presence.
Thank you so much.
Thank you.
Once again, it's a last but not least,
we have now a shared topic, shared presentation that will be presented by our Dr. Salim Al-Dahi and Dr. Rana Al-Hilali. Dr. Salim Al-Dahi, he is a consultant family and in the home health care with more than 28 years experience, having more than 7 local and international publications. He is a director of the home health care services team in Riyadh. Let the floor talk more about you, Dr. Salim Al-Dahi. And also he will talk about the home health care and caregiver experience. Also, we will not forget Dr. Rana Al-Hilali. Dr. Rana Al-Hilali also, she is a consultant family medicine at the home health care
Ministry of the Health in Al Madina region. She's also head of scientific committee in Saudi Scientific Society of Home Health Care. Also, she having experience of publication of international presentation. So, floor is yours.
Okay, thank you very much, Mahmoud. Assalamu alaikum wa rahmatullahi wa barakatuh. We are honored, me and Dr. Rana, who's really prepared and shared with me this topic. I think the importance of caregiver أو مرافق المريض أو القائم على رعاية المريض is very important. Home health care different from health care and primary care or secondary care or tertiary care. We have here a partner, and this partner is very, very important as our home health care team. This is the caregiver, and the caregiver journey is very important. Most of the studies show that if you have expert or at least committed caregiver, the quality of life of the patient will improve by 40%. And the life expectancy, yes, will increase by 6 years. نعم نؤمن نحن ان الاعمار بيد الله, ولكن again if you have excellent care, the average life expectancy will increase. Also, the cost minimization will reduce by 55% compared to secondary care and tertiary care. And again, readmission will reduce by 44% into emergency room or to the specialty clinic, all admission to the hospital. So this is the important. So I will let my colleague, Dr. Rana, to speak about the burden and the health of caregiver.
Thank you, Dr. Salim. First of all, I would like to thank Fakeeh group to give me the chance to be here, and I would like to thank the scientific and organizing committee and Dr. Mirfat, special thanks. Also, I would like to thank all audience who interested till the end to attend the caregiver experience, and also I would like to thank the audience online. Thank you, Dr. Salim, about your talk. When we talk about the caregiver, before we start the discussion, I want everyone in the room to remember when you was the caregiver for someone you love. For example, your parent, your kids, even for a short period of time for acute cases. How about those taking care of their loved one for long period? So what is the caregiver and what the health impact and psychological burden, and would like to know more about burnout, and finally then what to do with them to reduce this burden. Nowadays we find that the more patient become, the elderly patient become have chronic disability, they want to take care at their home. So the family have the major responsibility of taking those patients. So they name those patients in United States health system as isolated army for them, invisible isolated army for health system. Also, as we know, taking care of patient, beloved one, have a positive impact on the patient. Also, it have a burden on the caregiver if he don't know his limitation. So, the caregiver can be defined as hidden patient. What the literature say about the health effect? The caregiver, it could be themselves become ill, and they have viral illnesses longer, and caregiver have more depression and more insomnia. 50% of them have at least one chronic condition. 1 in 5 have poor health, and 70% of health deterioration as a result of providing of the care. And they found in the literature, when they compare the spousal and non-spousal caregiver, they found that they have higher Framingham by 23% than the spouse they not are care provider. Also, they found that 63 63% increase in all mortality in 4 years, 50% decrease in their ability of providing the care. What about the psychological issue? Also, the literature find they have more prone to depression when they compare to non-care providing, and they have more anxiety. This leads us to talk about the burnout. Burnout, it is defined when a state that when providing care to someone with ongoing extensive care, what the symptoms, what the cause, the problem, there is demand from the patient, not only from the patient, even the other relative. They are asked for the primary caregiver more and more and more. Also, according to the receiver condition, if it is hopeless case, it is increased the burnout, the role of confusion, and this is we will talk about the role. The more confusion, the more burden about burnout for the caregiver. But when they have more knowledge about the patient, they have less burnout. Lack of resources and money. And the symptoms, it could be the social isolation, lack of interest, loss in the appetite, and the changing in the weight. Also, changing sleeping pattern, getting more risk, and physically exhaustion, and become irritable. What is the cost? More mistake, decrease the morale, decrease the productivity, and they suffer in the personal life. The question, Dr. Salim, tell us about the book experience about assessing the caregiver burnout.
Okay, thank you very much. Burnout experience, we try not to do what you call it Maslach questionnaire, which is international, but we try to put 7 or 8 competency for the caregiver, and then to measure the burnout. طبعا the competency, like we do the nurse competency, start from the referral, when they refer to the home care, the response of the caregiver or the family, and the caregiver. طبعا there are two caregivers. We call it direct caregiver and indirect caregiver. The direct, for example, the son, who's come and take his mother or his father, and the indirect, the indirect and the direct, the one who can serve the patient, like for maybe also family member, or maybe housemaid, or maybe a nurse, or whatever. Okay, so these are different. We try to do more than 12 factors, but by statistic and the significant association was lack of training, and very important, all of them said ما في حد علمني، ما نعرف ايش نسوي. Okay, of course some of them they said they cannot offer everything for the patient because of the money. This is association, and educational level as well, not medical education or not health education, but in general. Okay, again the disease, but it was not significant. We find the dementia, the demented people, and with the Alzheimer or the palliative care patient or patient respiratory problems, also they have more, the caregiver have more burnout. One of the problem we found also, the very important, as Doctora mentioned, is they got insomnia, because the patient sleep most of the day and he woke up at night, most of the night. So this insomnia made them more tired and get them more burnout. Some also, one of the problem with the burnout, single caregiver. البيت مثلا يكون there are 3 siblings or 5 siblings, but one of them is the caregiver. Some families no, they would schedule everybody, for example, day, night, or daily basis. Yes, this is very excellent. But we found out the single caregiver have more burnout than the shared family members caregiver. Again, the other problem also, the caregiver, if the caregiver have other duties or shared duty, like مثلا housemaid مثلا شغالة, she work for the house work and
the patient, caregiver. Again, this is another factor we found is increase more of the burnout. Also, sometimes if the family does not know the medical problem or the prognosis, they not share the caregiver. Patient of palliative care or patient with post-stroke, and what's the service he need to be delivered. Again, we found the caregiver get burned out. He said, I don't know what is going on, how I can help. Again, also one of the problems is our problem, the time for the visit. Sometimes some home health care teams, 10 minutes, 20 minutes, they don't give enough time to discuss with the caregiver or to review the patients or talk about the drugs, the medication, and the instruction for the medication. So this is most of the factors which affect or increase burnout among caregiver. But by statistically, as I mentioned, the significant is the training, the income, and the educational. But factors, it go more than 12 factors. And really, we have a rule, we should have a rule as home health care team members to improve these factors, okay? And now I would like Doctora to talk about dealing with caregiver burden.
Thank you, Doctor. So we will talk about, as in home health care, as a staff, to decrease the burden, how to deal with the burden of caregiver burden. First of all, as Dr. Salim said, we have to emphasize our roles. We are the staffs entering the home, seeing the patient, seeing the caregiver. So we have to start by ourselves how to assist those caregivers. First, they have to be assessed once the patient is enrolled in home health care and the caregiver assigned. And as mentioned, Dr. Salim, the caregiver we have to select the caregiver if we have the possibility of that, more than one caregiver. So we will start our roles as a provider, as an initial assessment, also to become a counselor or advisor for the caregiver. If you see the patient or the caregiver becoming a change or in burden, we have to counsel them or to direct them where to go. Also, as a staff, we have to do assessment or screening, either the screening tool or to use the Zaret burden interview. And in Medina, we are trying now to apply it for our caregiver. This is example of screening tool, and this is the adaptive Zaret interview. I don't know, Dr. Salim, did you use it in Tabuk?
Yes, please.
And how do you find the percentage of burden?
Again, I think we start to use it from last year, but I don't have the analysis.
But it's difference. We have to screen them, then to follow them, and the higher score, that means they have more burden. So also as a staff, we have to emphasize to help to counsel them about these things: the stress management, time management, and lifestyle management. We have to counsel them about exercise and to ventilate, to ask them if they have someone trusted to ventilate. It is okay to ventilate. Sometimes in our society, when they starting to complain, they told me from restless of you, no, this is your father, you have not to be complaining. It is okay to complain, to ventilate, to set limits. Very important to have time to fun, and it is okay to cry. And this is also an issue. When the caregiver start cry, we try to stop them. No, let them cry. And also we have to counsel about avoid self-medication. Also, it is very important to help them to do list. And there is technology help them, application, how to do the list. Also to delegate when possible. This is very important. They have to be more than one. So they can distributing the responsibility between them, the caregiver. Also to encourage the healthy lifestyle. Here, we have to emphasize the role of the patient himself or herself. We have to talk to the patient if they are conscious and to remind them if they can do something by themselves, do it. Don't ask the caregiver. Also express good manners. Sometimes they become upset, but it is okay if the patient tell especially the relative or the son or daughter, thanks, thank you, or smile in front of them. The smiling, it affects a lot, and making dua also the same things. And be agreeable to change and demonstrate love. This is one of the most important things, the caregiver support. How to support them? When they have education and resources to have more information about diagnosis and to involve them in care plan. And they found that when they have more knowledge and more involvement in care plan, there will be reduction in the burden. And try to access the educational material. There is an application, help them to schedule tasks, and they have online program, and to use the smart home environment to allow the caregiver, they can monitor the patient from remote. Also, telehealth now an option to discuss the cases with the home health care team. Now, I would like to ask you, Dr. Salim, about the caregiver training program. Can you tell us about it? Because it is, by evidence, is the one of the best things to support the caregiver.
Okay. Of course, there are course by the Saudi National Home Health Care Committee. We have subcommittee called Caregiver Training Program. We started this program for TOT, or training of the trainer, and this program talk about most of the service delivered by home health care caregiver to the patient, and how to monitor it, and how to assess and evaluate this one. As I mentioned, I think last year we conducted this course in Fakeeh Hospital here, and I think some of the audience attended. طبعا الرياض مدينة المنورة, Jeddah was in Fakeeh, Abha, and Dammam. And we planned, and this year the manual being added, the pediatric home health care caregiver. I think they will start it next year again in Riyadh, to start from Riyadh and to go to the other province in the kingdom. So I think, as I said, we always said caregiver is a real participant and a real important member of home health care team. Even sometimes say it's more important than us, because when you go to visit, we go for 30 minutes, 1 hour, but he is there 24/24, 7/7. We have an experience in the last Saudi Home Health Care Day by the Saudi Society for Home Health, Scientific Society for Home Health Care. We selected the best 20 caregiver, and we make a dinner for them in one of the hotels in Tabuk, and we give him rewards. And this is really encourage the other to work more and deliver more service to the patient. And they all of them said, we should appreciate and thank your service, not we should thank because we are serving our parents or our family member. So please, my message, don't forget the caregiver. The caregiver is essential member of home health care. Whatever we deliver without skilled, clever, or committed, competent caregiver, you cannot do anything, or the patient health status may be decline rather than to improve. So I think caregiver should be considered very, very important for home health care service.
Thank you. Also, I would like to share an experience in Medina, spiritual support for the caregiver. Actually, every celebration of Saudi National Day of Home Health Care, We try to sit with the patient and the caregiver, and with them, and I make like a fun with them. One time take them to Umrah, for the patient and the caregiver, and to take them to روضة الشريفة في المدينة المنورة. And last year we take them to garden to sit with them. And last week we take the caregiver, maybe 25 caregiver to Mecca to make an Umrah, and it was rewarding. And some of them told us we maybe 5 years we don't go out from the home. So this is very important to think about them, to try to help them as soon as possible. As Dr. Salim said, they are primary in our team, in home health care team. Finally, just I want to share this recommendation in caregiver burden. As we told, as a staff, we have to screen to do assessment for caregiver burden. Also, I want to emphasize about the importance of psychoeducation, skill training, and therapeutic counseling intervention for patient and caregiver, especially in special conditions like dementia and cancer, stroke, heart failure. It shows its decrease in the caregiver burden. And we have to remind something for the caregiver. We have to tell them you have 2 hands, one to help yourself and one to help the other. And thank you.
Thank you. Just one point I would like to emphasize here, and there by law, when you visit the caregiver, you are allowed to give him a paper if he's working to his job that he was attending for 4 hours. Okay, should be officially to be given to the caregiver when you visit them if he's around, and then their work will accept them as a caregiver for this patient. Okay, any question or comment? You are most welcome. تفضل دكتور.
I'm afraid, or I doubt if I try to make screening for the caregiver in front of the family about their burden, that the family may make trouble with me, that why you discuss about this issue, they may ask more money, they may ask like this. Is it applicable to make screening, or because it's as per recommendation, it's a must? I feel there is some difficulty to make screening.
It is this is the staff ways how usually in the home health care the staff is having a rapport with the patient and the caregiver, and I think I think now problem to ask them. It is if I will review it, it is not offensive for them. It is just asking about mental health and social. I will ask him how many times they will ask for help. Do you go out? This is a simple question. I think it will not bother them, but it is important for us, because if the patient, the caregiver, enter to the burden, the service for our patient, it will be affected.
I think I do agree with Dr. Rana. The approach. طبعا usually for us, for example, or for when they refer to you, the patient, طبعا the social worker should do what you call it social worker survey, and from this survey you can know the family members, how many people live within the patients, and who those are. This is one approach. Second approach, you will have an idea about the status, especially economic status and their income. And really with those who have good income, we always, especially if the patient bedridden, always ask them to get, if they can offer a nurse or assistant nurse, if they can offer a housemaid, but a housemaid only for the patient, not for the house, not to do the household work, only for the patient as caregiver. Again, for example, if you have the 2 daughters and they are not working, or they have, for example, sons, whatever, by this approach, you can know the families. Really, as Dr. Rana correctly say, you will have rapport with the patient. You have a good relations. The patient, you will feel you are one family. They come to you every time, they consult you, they speak to you. So it depends on the approach. If you approach them, most of the family, yes, there are difficult families. I do agree with you. They said, why you are interfere with us? Leave the patient, we will manage ourselves. You are right. شكرا دكتور.
يعني another part of the question.
نعم.
Sorry for a
لا
long
لا
question.
الله يحييك.
Because we face when we visiting the patient, sometimes we need to give endorsement or recommendations or changing medication, and we found the caregiver. Can we depend to give this recommendation to the caregiver alone without referring to one of the family member, or can we fix it?
Yeah, most of the time you can. If you can, yes.
For the medication, because
Yeah,
some of the patient may call us, why you didn't inform me, you should inform me.
He is the direct caregiver. Okay, yes, the son and direct caregiver, because the direct who serve the patient, or you can convey the message to both of them.
If it's applicable, okay.
Yeah, you can do it.
Maybe there is a difference between the private sector and the governmental sector. Maybe I've been in governmental sector in 10 years in home health care, and now I'm joining Fakeeh for 2 years. There is quite different rules and regulations, and I think it cannot be applicable. Even the insurance company, we have an issue with them if we can talk with the caregiver as the first liner. I don't think we can do it. Maybe we'll find a way, Dr. Salim, في المجلس الصحي السعودي, to in our subcommittee for caregiver. Maybe we'll work for such legalizing or put it in our guideline, and everybody can work on it, and everybody are entitled to do this, whether it's private or governmental. I think we have a problem in the private sector. We cannot do it.
Good. Also, as the Doctora now طبعا we'll try to do what you call it volunteer caregiver. I know this is there is an experience in Bahrain, Oman, Qatif, but this one need legislations, law, we have to work on it. So this is, if you don't have, then you can, especially عندنا منصة التطوع الصحي والتطوع volunteer work, and now our kingdom is يعني they encourage the volunteer work, and by 2030 I think Prince Mohammed bin Salman, the crown prince, he expected to have 1 million volunteer in the kingdom, and one of the job maybe, but احنا مشكلة القانونية ودخول البيت وكذا, if have under legislation and law, then this will help, as Dr. Merfat said, even the private sector, not only the government sector. So I think yes, it is very important, as I mentioned. So I can conclude that caregiver is active participant in home health care patient management. Very important with us. He will improve a lot of the quality of care delivered to home health care patient. And thank you.
Thank you so much. Thank you so much for this valuable. We enjoyed actually for your presentation. Okay. Do you have any question in this presentation, or even before, with backed panel? No questions. I'm sure that the physiotherapy as one of our muscle in the home health care. Please give them round, please. Thank you. I think Mr. Ayman, he have a successful story, so he can mention it to us.
Good afternoon. I'm Ayman, physiotherapy at Home Healthcare. We have a lot of successful story in our home health care, especially under patient they come from Bubabak, they referral from our doctors. One of the successful story that we have, we are sharing at all. I'm talking now about all BTs, not only me. One of the case, the most resistance that we are facing is the patient, his psychologist. You know, all patient is in depression. Sometimes the session that going only to talking with the patient because we want to make the patient feeling well about the BT. We had referral for one patient. He was stroke. He was acute stroke. So he was totally bedridden. After we are working for 6 months, not only me and all my colleagues also. After 6 months, the patient, he is now, mashallah, is fully independent. He is going to himself. He is going to do his active daily life, independent himself. The first thing that we are facing was he's in depression. He's full depression. So 2 weeks that going to just talking with the patient, talking only with the patient. Then after 2 weeks, when the patient feel comfortable to the physiotherapy, feel comfortable to the person who came, we started our management to him, to his case. We use electrotherapy. We use the proprioceptive neuromuscular facilitation with him. We use all the modalities after 6 months. This patient now is independent. And also we have a lot, but I would like to thank my great team, is the BT team. And thank you for all.
Thank you so much. Again, our muscle in home health care. Okay, thank you so much. Before we are closing our program today, we need to give the floor for Dr. Salim Al-Dahi to give his valuable recommendations.
Okay, السلام عليكم. طبعا thank you very much Fakeeh group. Thank you Dr. Mirfat. Thank you for the nice team, the scientific committee, our colleagues, speaker, audience. It was very informative days. And we just, from the presentation, we have 6 recommendations. The first recommendation, as we heard in the morning, tele home health care and virtual clinics or virtual home care need to be implemented, but through guidelines, policy, and procedure. And I am sure the virtual hospital project, which is very big project by OMOH, if it can, by their cooperation, we can have these guidelines. Okay. Second one, home health care standard, which by Sabahi, which more or national standard, need to add the caregiver and the environment, as we mentioned in the morning, the home visits to be a standard of Sabahi, of the national home health care. Number 3, okay, the importance of the psychiatric illness and home health care are major ones, and so they recommended to have a mini symposium or 1 day or half-day symposium to discuss the management of psychiatric illness among home health care patients. Number 4, due to technology in wound management and wound healing, which is every day we see vac therapy, whatever, enzyme treatment, so should be studies for our caregiver. وشكرا لكم والسلام عليكم ورحمة الله وبركاته.
Thank you, Dr. Salim. Thank you, everybody. Thank you, our prestigious, honorable speakers for today. It was really valuable insights that you have been sharing with us. I would like to thank you all for your participation today, for your attendance, for your interest in our symposium today. Special thanks to the home health care team, nursing, PT team, physician as well, despite the overwhelming workload that you have. You are here today full duty. Thank you so much. I really appreciate it. Last but not least, we would like to honor and award our speaker for the last session, which is Excellence in Home Health Care. Please give a round of applause for Dr. Ahmed Tulba for his speech on new trends in wound management. For the burden and the caregiver experience in home health care, I would like to thank both Dr. Salim Al-Dahi and Dr. Rana Al-Hilali. You can come, Dr. Salim, first. شكرا لك دكتور. As well as Dr. Rana, thank you for your valuable insights. Thank you all. I would leave the mic for Dr. Mirvat for the closing. I really appreciate your attendance. دكتور زياد طب دكتور نادي الدكتور زياد Okay. So we are as a home health care, we would like to extend our appreciation to Dr. Mirvat for her support. She has been always the first, the middle and the last support for home health care team. Without her, such a wonderful symposium would never have been happened. I really appreciate this. Can you please, all the team, you can join us, please.
انت توقفي هنا.
Thank you so much. Really appreciate it. Thank you. Have a great day. Thank you.